So here's an outline of the topics we're going to discuss. I'm going to go a little bit quickly through some of the topics, and I'll spend a little bit more time on topics that I feel people sometimes struggle in neurology with. So we're going to talk briefly about the neurological exam. So when examining a newborn, the head circumference is very important. So the head circumference can tell us a lot about the brain. So the main stimulus for the head to grow is brain growth. And so if you have a child with microcephaly, it probably means their brain is not growing. Not only that, but you can tell a lot about just the general, not only the brain, but everything that's going on around the brain. So if there's a macrocephaly, so a large head, it can indicate that there might be a lot of fluid that's accumulating. So it's good to do serial checks of the head circumference to see how it's growing. When looking at the motor exam, we want to check tone. Tone is very important for babies. So we check the central tone, so looking at the core muscles of the body, and we look at the peripheral tone. So for the central tone, you can hold them up and see if they start to slide through your hands. You can kind of drape them over your hand with the head kind of facing down, and they should try to arch their back a little bit and kind of do a little bit of a Superman thing. When checking the peripheral tone, you'll move the arms and legs around, make sure that you're not meeting any extra resistance, and make sure that they have some degree of tone. So they're kind of fighting you a little bit. You don't want to make sure that it's not completely floppy. So when looking at the tone, there's two examples of different types of gait that is mentioned here. So a waddling gait would be in somebody who has very low tone. So what happens is if they can't get their legs off the ground, they'll kind of use their whole body to waddle like that, kind of like the penguin in Batman. And on the other hand, there's the scissoring gait, which is seen with spasticity or upper motor neuron lesions. And what will happen is they can't fully bend their knees and their other joints, so they'll kind of swing their leg around and scissor it, so one in front of the other. When looking at the sensory exam, if you ever find any areas where they might not have symmetry on the two sides as far as sensation, you want to follow it up and see if you can get to a level at which point proximal to that level they'll have normal sensation, and distal to it they might not have that sensation. Looking at the reflexes, so grade 2 is a normal reflex when checking the deep tendon reflexes with a hammer. 3 would be brisk, so if you strike the tendon, you get a little bit more quick of a jerk, or a bit more of a dramatic response than you're looking for. And 4 would be clonus, so if you strike that tendon and you see constant movement, that would be clonus. A 1 out of 4 would be hypoactive, so you strike it and you might see a little bit of a response, or sometimes you can feel a response. So if you're holding the limb and you strike it, you might feel that response. And 0 would be completely absent. When looking at the plantar responses, so if I were to check all of your plantar responses, yours should go down. So the big toe would go down. In babies, it goes up. And it goes up until around the time that they start to walk, which is usually around 1 year of age. And that is basically the time. Once they start walking, those tracts become myelinated, and the toe goes from upgoing to downgoing. And then they should have a downgoing toe for the rest of their life until and unless they have some kind of neurologic dysfunction or pyramidal dysfunction. When looking at the infantile reflexes or the infantile automatisms, there are certain ones like the Moro reflex and rooting reflex, and most of these reflexes are all kind of inborn reflexes for survival. So the rooting reflex is one where if you stroke the cheek of the baby, they should turn to the side that you're stroking. And likewise, if you stroke below the lips, they'll extend their head downwards and look for that stimulation. And it basically simulates the mother's nipple. They think they're going to get food, basically. So everything is for survival in that neonatal period. So the the rooting reflex is a feeding reflex. Moro is more of a survival reflex. And the parachute reflex is one where if you drape the baby over your hand and you kind of bring them down, they should kind of extend their arms and legs to break their fall. That's also more of a instinctual reflex for survival. And hopefully that's one that they never outgrow. So if I were to throw any one of you out of a window, hopefully you would try to break your fall. All right. When looking at upper motor neuron signs versus lower motor neuron signs, the upper motor neurons are mainly in the brain and the spinal cord. The lower motor neurons are everything that we consider the peripheral nervous system. So it's the anterior horn cells, the nerves, the brachial plexus and the lumbar plexus, the neuromuscular junction, and muscles. So signs of an upper motor neuron lesion would be spasticity or brisk reflexes, sometimes clonus. There can be a lot of times seizures, cognitive impairments. They can have bowel or bladder dysfunction. And a lot of times, it's lesions in the brain or the spinal cord, or sometimes both. So multiple sclerosis is a very good example of a neurological process which can affect the brain and the spinal cord, or it can affect one or the other. So sometimes it can affect the spinal cord and not the brain. When looking at lower motor neuron lesions, there'll be a lot of times flaccidity of the muscles. There'll be hypotonia. Reflexes can be absent or hypoactive. They can have Gowers' sign. So Gowers' sign is a sign where if you ask your patient to sit down on the ground, most people, normal people, should be able to stand up without excessively using their hands. But somebody who has a weakness of some sort will need to kind of push themselves up off the ground and kind of walk themselves up their body with their hands. That would be Gowers' sign. And so examples of lower motor neuron lesions would be any kind of muscular dystrophy, any kind of myopathy. Myasthenia gravis is within the neuromuscular junction, as is botulism. So these are all things which can affect the peripheral nervous system. All right, we're going to talk about brain malformations. So a few that we'll talk about are neural tube defects, Chiari malformations, and malformations of the cortex. So anencephaly would be the most severe neural tube defect that we're going to talk about on this list, and spina bifida is a little bit less severe. So we'll kind of go through each one of these individually, and we'll do a quick crash course in embryology. We'll talk about the neural development embryologically. So by day 17 of gestation, we start to see the neural plate, and below the neural plate is the notochord. So the neural plate on day 18 starts to invaginate and make kind of like a U-shaped structure. And within the third week, that U-shaped structure starts to close, and it forms the neural tube. And by day 24, so we have that whole long neural tube, the anterior end, or the cranial end, closes by day 24. And the posterior end closes by day 25. So those are very important dates to remember. I've seen in our neurological, in our neuro board review, and on the exam, they asked that a lot. So that would be one that, those are dates that I would recommend remembering. So if there's a problem with the closure of the anterior neurotube or the posterior, you can have problems within the brain or spinal cord. So here is a diagram. We have the neural plate at the top here, and the beginnings of the neural groove. The neural grooves start to invaginate over here, and they start to close right around here. And we have a fully closed neural tube with the anterior or cranial end here, and the posterior or caudal end here. So cranial obviously means the head, caudal means tail, so that's the tail end of the spinal cord. So if there's problems with closure of the anterior neural tube, you can have anencephaly or encephalocele, which we're going to talk about, and the posterior end will have myelomeningocele, which is shown in this picture here. So anencephaly. So enceph means brain. A means without. So there's no meaningful brain there. And it's a very severe complication of malformation of the neural tube. And what happens is that anterior end or the cranial end does not form or doesn't form properly. So there could be a rudimentary form of a brain present, but it's not typically compatible with life. So kids who are born with that, if they're not stillborn, they usually do not survive more than a few hours. And it's basically the anterior neural tube did not close at the way that it should have. That usually occurs around day 24, as I said, and a lot of times at that point in gestation, a lot of people are not aware that they're pregnant yet. So by the time pregnancy has been determined, a lot of times the neural tube has already been formed. So it's sometimes a little bit late to start taking the folic acid. With anencephaly, there can be a lot of midline defects, so there can be some facial abnormalities with the eyes, with the nose. The pituitary gland is also a midline structure, so that there can be abnormalities with the development of that gland. And any kind of neural tube defect, there can be abnormalities in alpha-fetoprotein. So if tests are done, you can detect a possibility of a neural tube defect by seeing very high levels of alpha-fetoprotein. Encephalocele, so this is basically, if we break down the word, cele means sac, and ceph means brain, so it's basically a sac containing the brain. And what happens is this is also a malformation of the anterior end of the neural tube, and so there'll be some kind of bony defect, usually in the occipital region of the head, or through the upper part of the spine. And the lower part of the brain can kind of herniate and come out through this malformation. And so in this picture, there's a defect somewhere in here in the occipital region, and this whole thing is not going to be brain. The brain is probably just taking up a small amount of that. But what happens, it's kind of like a balloon. And so there's no skull around any of this. It's all just skin. And so what happens with a balloon, if you keep putting water into it, and the water would be the cerebrospinal fluid here, is it just keeps growing and growing and growing. And eventually balloons can pop. So hopefully that won't happen here. So kids like this are usually taken emergently for surgery, and they kind of repair that defect and push all the contents back in. They might have to drain out a lot of the fluid also. Most of these are seen in the occipital region, and these are very oftentimes picked up on fetal ultrasounds. And again, with all neural tube defects, there can be increased levels of alpha-fetoprotein. All right, and then we have a myelomeningocele. So myelo means the spinal cord. Meningo means the meninges, which cover the spinal cord. And cele, as we said, means sac. So it's a sac containing the spinal cord as well as the meninges. And so what happens in this image, we see there's a sac right here, and the blue is the spinal cord, but along with the spinal cord, it's taking the covering of the spinal cord, which would be the meninges, it's taking that with it. So we have the spinal cord and the meninges in this sac. And so it's usually seen at the lower end of the lumbosacral region, and it can affect things below that level. So there can be spasticity or flaccidity in the legs. There can be bowel or bladder dysfunction. Reflexes can be affected. You can have decreased reflexes. There can be some hip issues, some knee issues, some feet malformations also, the club feet. This can oftentimes be seen in conjunction with a hydrocephalus or a Chiari type 2. We're going to talk about the different types of Chiari a little bit later. And because it's further down in the neuroaxis, it's not affecting the brain per se. So they can have normal intelligence, they can have normal, to an extent, normal development, and with surgical correction, a lot of times they can do fairly well. The treatment is surgery. A lot of times they can have, with the Chiari-2, they can have increased fluid, so sometimes they need a VP shunt to take out extra fluid from a hydrocephalus. And this can sometimes run in families, so if it's seen in one sibling, it can be seen in subsequent siblings. And it can be seen higher if the mother was taking valproic acid during pregnancy. So the dose of folic acid is something that I used to always forget. When I was a resident, people would ask me, what's the correct dose of folic acid? And I would always have to look it up. So, and I would always get hung up on the units, right? So there's micrograms versus milligrams. So it's 0.4 milligrams for all females. And it's 4 milligrams if they've had a previous neural tube defect, a previous child who's had a neural tube defect. So, I used to get mixed up with the micrograms versus the milligrams. So always try to keep that straight. Remember the 0.4 milligrams and the 4 milligrams. The meningocele is basically, we have that sac again, the seal, and the meninges, right? So there's no myelo associated with this, no spinal cord. So it's just the meninges coming out into that sac. So the cord is intact. And so what happens, again, this is in the lumbosacral region, and this is a little bit less urgent because the cord is not being compressed, it's not being impinged in that sac. So they will go in and kind of push the contents back in, reinforce the area, but it's not as emergent as a myelomeningocele. A lot of times this can be associated with tethered cord or diastematomyelia. That's basically a split in the cord. So you have the spinal cord coming down, and at some point it can kind of split into two cords running side by side and then join back again into one cord. So that can be also a malformation of the cord. And if this meningocele does not have a skin covering on it, then it would be more emergent. But if assuming that there's skin covering the meninges, then the surgery is not as emergent. All right, and we have spina bifida. So this is a midline defect in vertebral bodies. It's usually in the lower end of the cord, in the lumbosacral region. And so what happens is there's a communication. So if you look at this image, we have a communication here. So there's a vertebral defect, and there can be a potential exposure to the cord and meninges. And a lot of times there's a tuft of hair overlying it. So if you see a dimple on a baby, you should try to spread that dimple apart and see if you see the base of that dimple. If you see the base, chances are it's a little bit more benign, but if you don't see that base, you would want to send them for an ultrasound very quickly because you'd want to make sure that there's no direct communication with the cord. And that communication would be a dermoid sinus. So that can be something which is potentially concerning. All right, and so the folic acid, we mentioned that 0.4 milligrams should be what all females are taking. So hopefully we all are counseling our patients, our female patients, to be taking folic acid when they're of childbearing age. And if they've been previously affected, if they've had a previous child with a neural tube defect, then they should be taking 4 milligrams per day. All right, so now we'll talk about Chiari malformations. So let's look at the image first. So do we all know what we're looking at here? So this is a brain. And is this an axial view, a sagittal view, or a coronal view? Sagittal, so it is a sagittal view. So the way that I remember it, and when I was in peds, I didn't know anything about neuroimaging. So if you already know the different views, then you were better than me when I was a peds resident. So this is a sagittal view. The way that I remember it is axial. If I was going to chop off somebody's head, I would take an axe and take a nice slice off like that. So it's kind of like a slice that you're looking at from above. Sagittal is a side view, right? So sagittal and side, I remember the S. And then coronal, if I was being knighted by the queen and she's putting a crown on me, she would be standing in front of me, so it's a frontal view. That's just stupid ways that I use to remember things. So this is a sagittal view. And what we're looking at here, we have the cord coming down here, and this is the cerebellum. So we make an imaginary line right across here. And all of this that's coming down below that imaginary line is abnormal. It should not come that low. So this is a Chiari malformation. And you would kind of make those lines and use the measurement to see how far down it's coming. If it's coming more than ½ centimeter or 5 millimeters, then that would be considered a Chiari malformation. These can oftentimes be associated with a syrinx or syringomyelia, so that's basically a cystic space. It's usually a linear cystic space within the cord. There can be various symptoms, and they don't always go in and surgically correct these. They go in and correct them if they're having very bad headaches, if they're having cranial nerve dysfunctions, if they're having vertigo, any other kind of ataxia or spasticity. So if they're symptomatic, they usually go in and they might correct it. But a lot of times for headaches which aren't that bothersome, they'll usually just do headache treatment for it. And when they want to go in and do a surgical correction, they'll do a suboccipital, so they'll go in through the back here and kind of push the contents back in and reinforce that area. So it's called a suboccipital decompression. So a Chiari 2 is a Chiari 1 with some additional things. So we take what we talked about in Chiari 1 and we add in the hydrocephalus and a myelomeningocele. So that makes up the Chiari 2. Usually the fourth ventricle will come down lower into the foramen magnum. And so when that happens, there's basically an obstruction of flow of the cerebrospinal fluid, and that's where you get this hydrocephalus from, because that fourth ventricle is being compressed. So it's kind of blocking the plumbing. So the fluid has nowhere to go, and so you start to get hydrocephalus. They can have very similar features as the type 1, so they can have the cranial nerve dysfunctions. And it's important to keep in mind that that foramen magnum area is kind of a narrow passageway. And so if you start crowding it with tissue and everything, other structures such as the nerves and arteries and other vessels can start getting compressed. So in this kind of situation, a surgical correction would be done sooner than later. Chiari 3 is everything that a Chiari 2 has. Plus, there's herniation of the cerebellum through a cervical spinal bifidus. So there's going to be some kind of defect within the cervical vertebrae, and the cerebellum can protrude outwards from there. And we'll talk about some migrational anomalies. So the neural tube, once that's formed, it starts to divide into 3 different structures. So we have the prosencephalon, which is the forebrain, and we have the mesencephalon and the rhombencephalon. The prosencephalon further divides into the telencephalon, which forms the 2 cerebral hemispheres as well as the basal ganglia, and the diencephalon. So that forms the thalamus, the hypothalamus, the pineal gland, the optic nerves. The mesencephalon forms the midbrain, and the rhombencephalon is the hindbrain, so that gives off the metencephalon, which gives you the pons and the cerebellum, and the myelencephalon, which gives you the medulla. The brain, when it's forming, everything forms in the central area, and everything kind of it fans out from there. So the problems that can happen with migration is if there's a problem within the first trimester, usually by the end of the 3rd or 4th week post-gestation, when the structures are starting to kind of spread out and travel to the different areas. If there's a problem along the way, then it can stop and it won't migrate to where it's supposed to go. And you can have things like this, which is called lissencephaly. So in this image, we have a very smooth brain. So as we said, enceph means brain, and lis means smooth. So lissencephaly is smooth brain. So there's that loss of sulcations. You don't see the gyri like you normally should. So it's also called agyria. And so what happens is, depending on the severity of the lissencephaly, there's different degrees of how much of the brain is affected. But there can be failure to thrive, microcephaly, there can be developmental delays, seizures. Depending on how severe it is, it'll dictate how long the child can last for, but in the more severe cases, they may not live beyond a few years of age. It can be associated with certain chromosomal abnormalities. So Miller-Dieker syndrome is seen on chromosome 17, and it has this constellation of symptoms. There'll be a prominent forehead, so very kind of protruding forehead, and hollowed out temporal regions. So if you have an infant's head and you push on the 2 sides, the brain and the head will start to elongate anteriorly and posteriorly. And so that's kind of what happens here. You have narrowing in the temporal regions and prominence in the frontal region. There can be some lips becoming very prominent and thickened. There can be anteverted nostrils and micrognathia, which is a small jaw. All right, and schizencephaly. So as we said, enceph means brain, and schiz means split. It's kind of like schizophrenia. They used to think that schizophrenia was a split personality, but this is a schizencephaly, so it's a split brain. And what happens is during migration, as all of the structures are kind of migrating to where they're supposed to go, if the tissue that is supposed to be here doesn't make it to where it's supposed to go, there can be a cleft left here in the brain, and it communicates with the ventricles. So these are the normal ventricles right over here, and this one should be over here, except that that tissue did not form, so it's communicating outwards here. Depending on the severity and the location of the schizencephaly, it can cause seizures, microcephaly, developmental delay. There can be spasticity in the extremities. I just saw a 8-month-old girl who has schizencephaly, and you would never guess it. She looks totally normal, and we only knew it because she started having some seizures, but otherwise, developmentally, she was totally normal. So we're treating her seizures, and otherwise she's doing really well. All right, so we have holoprosencephaly. So this is when the prosencephalon does not divide. So instead of having two cerebral hemispheres, you kind of just have this one mass of brain tissue. So there's 3 types. There's alobar, which is the most severe. This is when there's basically just one solid brain mass. There's semilobar, where the tissue started to divide, but it didn't go very far. And then there's lobar, where it started to divide, but it didn't go all the way. Depending on the severity, it can have other anomalies also. So it can have cyclopia, so it can have one eye. Again, these are the midline structures. You can have the midline defects. You can have cleft lip, cleft palate, and other kinds of midline abnormalities. And this is what the cyclopia looks like. So it looks like there was maybe the beginnings of 2 eyeballs, but there's kind of one space. These structures did not divide. There's no nose present. There's small lips. All right, and here, if we look at this image, this is one solid mass of brain tissue. So there should be a division which kind of goes right along the middle here. So it did not form. You can have these other types of midline defects, so teeth abnormalities. You can have cleft palate, as I mentioned. And here also, you should see some degree of a split in the middle here, which did not develop. There can be another midline structure, which is called the corpus callosum. And so here is a normal corpus callosum. And so in some patients, the corpus callosum may not develop. So you can have agenesis. Genesis means the formation of, and A means without, so there's no corpus callosum that formed. Sometimes there can be a very tiny corpus callosum, a rudimentary one, but it's not functioning as a corpus callosum should. This can be seen in maternal cocaine use, as well as other genetic conditions. And a lot of times this can be picked up in a prenatal ultrasound. All right, and so we have hydrocephalus. So what happens is if there's an obstruction of outflow of the CSF, it can cause the head to grow. And this can be seen a little bit more so in babies before their fontanelles have closed, before the sutures have fused, because basically the bones in the skull in babies are designed to be free-floating, and they're designed to overlap and pass through the birth canal at birth and then kind of spring back into place. So if there's, for any reason, hydrocephalus before those sutures have closed, before the fontanelles have closed, then you can have a significant increase in the size of the head. If you look at images in somebody who has hydrocephalus, very often you'll see dilatation of the ventricles, and there'll be an increased pressure within the ventricular system. So when looking at hydrocephalus, you want to know, is it communicating or non-communicating? So what we have here is, if there's a non-communicating hydrocephalus, there's going to be an obstruction somewhere within that system of pipes within the brain. And when I mention the pipes, I mean like the whole outflow of the CSF. So you have the 2 lateral ventricles, the 3rd ventricle, the 4th ventricle, etc. So if there's an obstruction somewhere along the way, then it's non-communicating or obstructive. If there's that whole system is patent and it's flowing throughout, but there's a blockage somewhere outside of that system, then it's called non-obstructive or communicating. And then there can be a problem where there's too much CSF produced. So that can be treated a different way also. So here we have this is how the CSF flows. So you have the lateral ventricles, and they go into the third ventricle and then out through the cerebral aqueduct into the fourth ventricle, and then they go onwards through the foramen of Luschka and Magendie. So if there's some kind of obstruction anywhere along this pathway, then it would be a non-communicating obstruction. All right, and everybody good so far? Hopefully, yeah, all right. So when looking at increased intracranial pressure, it's very important to do a fundoscopic exam. And this is something that I try to teach my students, my residents, that they really need to learn a fundoscopic exam. So if any of you are going into primary care, emergency medicine, you really should practice a fundoscopic exam on everyone. So when you look at a fundus, you want to look for vessels. So you find a vessel and then you follow it. And as you get towards the fundus, the vessels get thicker, they get bigger. If they're getting smaller, that means you're going away from the fundus. So you want to find a vessel and follow it towards the fundus. And so here in this image, you see that the margins are a little bit blurred. Also, the color is not great of the fundus. So it looks like there's a lot of pressure behind in the brain. And so what are you looking at when you look at the fundus? You're basically looking at the optic nerve. It's the end of the optic nerve, which is an extension of the brain. So you can actually tell a lot about what's going on in the brain just by doing a fundoscopic exam. And so if there's increased intracranial pressure, the fundi might look a little bit blurred in the margins. The color might be a little off. It might be a little bit grayed. It should have some degree of some nice redness, some nice whiteness to it also, but you don't want it to be too pale. There can be some irregular breathing if the increased intracranial pressure is significant. The blood pressure might be elevated. There can be bradycardia. And very frequently, with increased intracranial pressure, you'll find that there's early morning headaches, early morning nausea and vomiting. And basically, it's because gravity is causing the fluid to go into the brain. So in the daytime, when we're upright, gravity causes the fluid to drain. When we're laying down for prolonged periods, as we do overnight, then the fluid can accumulate within the brain. And there can be a sixth nerve palsy, but this is a very non-localizing sign. So a sixth nerve palsy would show up as an inability to abduct one of the eyes. So beyond midline, the eye may not look outwards. So if I have the patient follow my finger, they won't be able to go outwards laterally with one eye. That would be a sixth nerve palsy. And the reason it's called a non-localizing sign is because the sixth nerve has the longest intracranial path compared to any of the other cranial nerves. And so it's more susceptible to pressure. If there's an increase in pressure, it can be compressed somewhere along its long tract. And so you would think, okay, there's a sixth nerve palsy, great, but you can't localize it because it could be anywhere within the brain that there's an increased pressure. You'll see papilledema, which we see in the fundoscopic picture over here. The head circumference can be enlarged, and a lot of times with increased intracranial pressure, there can be lethargy, there can be drowsiness, you can have a hard time arousing them and maintaining their attention. And you can see the setting sun sign. So this is an impairment of upward gaze. So the eyes will appear kind of lower than they should. And so you'll see the sclera above the iris a little bit more than you should. So when you look at somebody straight on, you should see the iris. You might see the upper rim and the lower rim of the iris and maybe a tiny bit of the sclera above it. But you shouldn't see a significant amount. So the amount that you see in this patient here is a little bit excessive. And if you ask a patient who has this to raise their eyes and look up at your fingers, instead of raising their eyes, they'll actually extend their head backwards to look up. because they have that, they don't have that ability in upgaze. And so with increased intracranial pressure or hydrocephalus, there'll be a dilatation of the ventricles. So this ventricle is a little bit more generously sized than this one. And it's kind of like, one of my professors used to always tell us to picture a balloon. So if there's a hydrocephalus, you think of it like a balloon in the ventricles. So the ventricles become nice and dilated. They lose that contour that they should have. And it becomes like a dilated balloon. So for hydrocephalus, you want to do serial head circumferences to see how quickly it's growing. You can do imaging either by a CT or an MRI to see if there's any visible obstruction along the outflow to the CSF. All right, and so in this image, so this is a sagittal view, right? I'm sure you guys remember my weird ways to remember the different views. So this is a sagittal view of the brain, and what we see is there's something right here which is obstructing the outflow of the CSF. It should come along here, but there's this mass here, which is not the cerebellum. This is the cerebellum. You can see that the cerebellum has that nice leaf-like contour to it. And here you have this big mass here, which is obstructing the outflow of the CSF. And this is most likely a tumor of some sort. In kids, tumors form in the posterior fossa more than anywhere else in the brain. And it can very frequently present with headaches and hydrocephalus because of the outflow to the CSF flow. I'm sorry, the obstruction to the CSF flow. All right, and so if you find hydrocephalus, you want to treat the cause. So if there's a mass there, you need to go in and take out that mass and kind of rebuild the area. A VP shunt can be placed to help drain the extra fluid. But the problem with VP shunts is that there can be infections with various organisms. So basically what you're doing is you're putting in a drain into the brain, and you're taking the extra fluid out of the ventricle and bringing the tube down, and it drains into the peritoneum. And so with that, there can be infections that can be caused. There can be kinking, which comes up somewhere along the line where the tube is running. And so very frequently, if people start developing extra headaches or extra seizures or anything like that, then they have to do X-rays and make sure that the pathway of the VP shunt is still patent. All right, so we have our first question here. So this is a 2-month-old baby who presents with increasing head circumference and bulging fontanelle. The exam reveals the following physical findings. So we have the arrow, which is pointing to a spot right here. So the most likely cause of hydrocephalus in this baby would be A, obstructive hydrocephalus caused by a tuber, B, intraventricular hemorrhage causing non-obstructive hydrocephalus, C, meningitis causing non-obstructive hydrocephalus, D, choroid plexus carcinoma, and E, not related to the findings shown. So let's take a moment. All right, and we have a vast majority who chose A. So what did we see in that picture? Ash leaf spot, right. It was kind of a pale, a whitened spot on the skin. And there was another one on the other side of the torso also. So one on one side of the back and the other on the other side. And so those, if you see that whitened spot on the skin, you should think of, what does it go along with? The ash leaf spot and tuberous sclerosis. All right, very good. And so with tuberous sclerosis, there can be tubers which form within the brain, and that can obstruct the outflow of CSF sometimes. And that's why this child had hydrocephalus. All right, we're going to talk about cerebral palsy. So the thing with cerebral palsy is that we're trying not to use that word as much anymore. For your exam purposes, please use it. But in practice, we're trying not to say things like cerebral palsy. We're trying to get away from things which have a negative tone to it, kind of like intrauterine growth retardation. We say restriction now. The reason is because a lot of people, when they think of cerebral palsy, they think of people who are in wheelchairs, who need breathing devices, and who are very severely affected. And it's not always that extreme. Sometimes we can see cerebral palsy, and it's just some tight heel cords. So sometimes it's kids walking on their toes. Now, having said that, not everybody who walks on their toes has cerebral palsy, but it can be as subtle as just some toe walking. And what it means is, so as I said, we're trying to use the word static encephalopathy. So static means non-progressive, and encephalopathy is basically a negative process within the nervous system. And so it's non-progressive, meaning that they're not going to get worse, but they may not get better either. So it's static. And a lot of times, they'll need various therapies, physical therapy, occupational therapy, to help them overcome and stretch out those muscles which are affected. So there's different types. There's a spastic form, which is most common, and so they'll have upper motor neuron signs. They'll have tightening of the extremities. They may not be able to walk appropriately. They'll have that scissoring gait, which we talked about initially. There can be a dyskinetic form in which they can have various types of movements. So they can have choreoathetoid movements. So chorea is like sudden flailing movements. They can have random jerks of their limbs. And athetosis is kind of a slow writhing movement. So if you combine the two, it's this athetosis with this chorea. It's not as common as the spastic type. There's also an ataxic type, a hypotonic type, and a mixed type. So a lot of times we'll see kids who can have increased peripheral tone, but decreased central tone. So that would be a mixed type of cerebral palsy. A lot of times seizures can go hand in hand with cerebral palsy, but having said that, not everybody with seizures has cerebral palsy, and not everybody with cerebral palsy has seizures. There can be intellectual disabilities, so they may have some kind of delays cognitively. They can have developmental delays of other sorts also. And so how do we treat it? Well, if they have the spastic type, we can treat it with Botox injections. We can do baclofen or diazepam to help decrease that extra tone in the limbs. If they have seizures, we treat them with anti-epileptic medications. I'm a firm believer in very aggressive occupational therapy, speech therapy, physical therapy. I think that the more that's done in a lot of these kids, the better their outcome potentially could be. Sometimes they need audiology, ophthalmology evaluations if there's concerns for their hearing or vision. And by far, the most common cause of cerebral palsy is prematurity and low birth weight, which is all on this side over here. A lot of times with prematurity, there can be intrapartum asphyxia, which is in this section over here, but a lot of times this can go along with the prematurity. There's a lot of other potential causes, certain infections which can occur in the neonatal period, or especially prenatal period, various metabolic conditions, chromosomal abnormalities, but by far the most common reason is low birth weight and prematurity. All right, our next question. We have a 15-year-old girl with spastic diplegia presents to the clinic with a recent onset of staring spells with leftward eye deviation. She has a history of being born at 28 weeks gestation. Exam is remarkable for spasticity and hyperreflexia in her legs. She has never had any regression in her cognitive abilities and no marked changes in her physical exam since her early childhood. Which of the following is the best initial step in treatments? A, psychotherapy and counseling. B, urgent psychiatric consultation. C, obtain an EEG, counsel of seizure precautions, and refer to neurology. D, start an antidepressant. Or E, start a workup for alternate causes of lower extremity spasticity. All right, very good. So almost everybody chose C, obtain an EEG, counsel seizure precautions, refer to neurology. So what is she having? She's having these unusual spells. What are they? Seizures? What kind of seizures? Well, she's having episodes where her eyes go to one side. So yes, she zones out, but her eyes are also going to one side. So that might make you suspicious for focal seizures. So focal seizures are a little bit different than absence seizures. Absence are generalized. So we'll talk a little bit about that coming up. But we're going to talk about stroke first. All right, so stroke is something that we see at the two extremes of age. So there's a bimodal age distribution. So babies can have stroke a lot more frequently than older kids and adolescents. And then it gets more common again in older age, in elderly people. And that usually happens secondary to strokes and other injuries to the brain, which can predispose people to having, they can have seizures associated with the stroke due to the injury. So in this image, this is a special type of image called a DWI. And this is very sensitive at looking for abnormalities in diffusion. And so we have this very bright area here. It kind of follows a vascular distribution. So this is a stroke. And so there's two main types of stroke that we see in kids. There's ischemic and hemorrhagic. And so ischemic is basically when there's a decreased blood flow to the brain for whatever reason. And sometimes there can be a hemorrhagic infarct in which there can be either trauma or something to the brain causing blood, and that blood can cause ischemia. So ischemic and hemorrhagic are the two types. With older people, it's usually atherosclerosis, which causes a stroke, but that's usually not the case in kids. So the clinical presentation varies according to what age the child was when they had their stroke. So stroke that occurs in utero, it can cause a hemiplegic cerebral palsy. So they can have one half of their body which might be stiff or hypotonic. They can have an affected hand dominance. So if their right side of their body is affected, it might force them to use their left hand a little bit more. So it depends on how old they were when it happened. If there's a perinatal stroke, very frequently it presents with neonatal seizures. And so seizures that are seen due to a stroke at birth, usually we just see them in the first couple days, and then we don't see them as significantly beyond those first couple days of life. But they can also have a lot of lethargy, poor feeding, mental status changes. So a lot of times if we do an EEG on people, on infants who might have these other findings, such as mental status changes or lethargy, if they're having difficulty maintaining their oxygen saturation, then we can sometimes see that they're having subclinical seizures. If they had the stroke beyond 2 years of age, they can present with seizures and hemiparesis. And in older kids, they can have focal signs depending on what part of the brain was affected. So there are certain things which can look like a stroke, but are not a stroke. So a Todd's paralysis occurs in some people after a seizure. And so what happens in a seizure is that if it's coming from one side of the brain, so a focal seizure, it can exhaust that half of the brain, basically, because the neurons are constantly repetitively firing and they get exhausted. So what happens is that brain, that half of the brain, can kind of become a little bit less active. So there can be a kind of a paralysis on the side of the brain, on the side of the body that side of the brain is controlling. That's called a Todd's paralysis. So it's a paralysis after a seizure. There can be complicated migraines in which you can have hemiplegia. We also call them hemiplegic migraines. And there's a genetic condition called familial hemiplegic migraine, in where if we see a child who's having a migraine and having half of the body affected, we can ask them, was there any other family member who had hemiplegic migraines? And if so, they can be treated with certain medications. There's also alternating hemiplegia of childhood. So this can be triggered by infections, by cold temperatures, by stress on the body. And sometimes it's associated with seizures, movement disorders, and cognitive delays. And this can be associated with a mutation in the ATP gene. So ischemic strokes, in kids, it's most often related to cardiac disorders. So if there's some kind of problems with the heart, that can cause a stroke in a lot of kids. There's also various other factors. So anytime there's a stroke in a young person, so even beyond childhood, in the teenage years or in the 20s, that's still a very abnormal time to have a stroke. Usually strokes occur in older age, and it's a little bit, not that it's normal, but it's a little bit more expected in that age group than it is in a young person. So in a young person, if there's a stroke, we start looking at these various prothrombotic conditions, such as a factor V Leiden deficiency, deficiency of protein C or S or antithrombin, lupus coagulant, anticardiolipin antibodies, antiphospholipid antibodies. So these are all things which can run in families. It can be genetic causes of stroke in young people. Sickle cell disease is also a common cause of stroke. And a lot of times what happens in sickle cell disease is there can be occlusion of a blood vessel. And what happens is it will form collateral ways, collateral circulation, so that those areas of the brain can receive their blood through collateral circulation. And when you do an image on those people, you actually see those collaterals forming, and it looks like, we call it a puff of smoke. That's very classic for moya moya. It's basically this kind of whole new small vessels that have sprung up to keep that area of the brain supplied by blood. Stroke can also occur after trauma, after arterial dissection, and after CNS vasculitis. So if there's any kind of problem with the blood vessels, if there's any kind of inflammation within the vessels, which can be either due to infection or immune-mediated, that can also cause stroke. And various metabolic conditions can also cause stroke. So with stroke, there's various conditions. The vasculopathy is usually one of the more common causes. There's, in this image here, I'm going to show you, we have a normal vessel right here. And the dissection is basically within the lumen of the vessel, there's kind of an outpouching. And so blood starts to form within the lumen of the vessel. And so here you get a narrowing within the vessel here, and you can see it here also. So the blood basically starts to accumulate within the lumen of the vessel, and it occludes that normal blood vessel. And so you have very thinned blood vessels in that region. Here are more causes of potential stroke. So homocystinuria and Ehlers-Danlos are somewhat common causes of stroke. Menkes disease. I have a patient with Menkes disease who had a stroke in the neonatal period, actually. So that is also another cause of stroke. So the left MCA is oftentimes affected with stroke more than the right. And the reason for that is because the left MCA is the middle cerebral artery, the left MCA kind of takes a little bit more of an acute turn. So it's a little bit more of a 90-degree turn than the right side does. And so in that turn is where if there's an alteration of blood flow or anything, sometimes with older people, there can be atherosclerosis or thrombi, which go and occlude that area, and they can get stuck right in that acute turning of the MCA. A lot of times also, if there's hypertension, in the neonatal period, if there's any kind of infectious processes, stressors, which are causing the blood pressure to be raised, that can oftentimes also predispose them to strokes. Very frequently, they'll present with seizures. So anytime you have a seizure in a newborn, you should get imaging. So very frequently we'll get MRIs of the brain to see if there's any specific reason why they're having the seizures. All right, and we'll talk about the hemorrhagic strokes. So there's a subarachnoid bleed. And so what happens is we have the different layers of the scalp. And within between the arachnoid layer, they can have bleeding sometimes. It's usually after some kind of trauma, but sometimes it can occur spontaneously. And people will very classically present with the worst headache of their life, and they can sometimes have seizures, other types of focal deficits, and at times there can also be intraparenchymal bleeds. So that's bleeding within the brain. And so blood in the brain is an irritant. So blood is usually not in contact with the brain tissue. And so if there's blood in the brain, it can cause seizures. So very frequently, people can present with a seizure, and we do imaging, and then we see that they might have a bleed of some sort. So there's different causes of hemorrhagic strokes. It can be due to trauma. Unfortunately, there's non-accidental trauma, which happens a little bit more often than we'd like it to. There can be bleeding disorders, so some kind of inherited condition where people can bleed more than usual. There can be vascular anomalies such as a arteriovenous malformation. So in this image here on the right, we have the arterial system and the venous system, and they should form a nice network like this. But sometimes if there's a malformation of the arteriovenous system, it can predispose to bleeding. So we call those AVMs, arteriovenous malformations. And here on imaging, we can see that there's an AVM here and a cavernous malformation here. So these are all different types of vascular anomalies. All right, our next question. In the setting of acute neurological deficit and suspected stroke, an emergent head CT without contrast is performed to A, identify and localize an area of ischemia, B, rule out acute hemorrhage, C, assess for a posterior fossa mass, D, we do not perform head CTs in children, or E, rule out an aneurysm. All right, and so the majority of you chose B, rule out acute hemorrhage. This is correct. And so basically a CT is a very quick study we can do, and it shows us a couple things. So the things that show up bright on a head CT are blood and calcium. So bone is very bright and blood is very bright. So we basically do CTs acutely to rule out any kind of bleeds or anything like that. All right, next question. A 16-year-old slim girl presents to the ED with a history of a new onset headache, vomiting, and diplopia. Fundus exam is performed in the image. In addition, she has weakness of abduction of the right eye. She reveals that she is on birth control pills and her mother had a stroke at a young age. The most appropriate initial course of action would be A, a lumbar puncture, B, CT head without contrast, C, an MRI of the brain, D, start her on acetazolamide, or E, obtain a neurosurgical consult for a possible shunt. All right, and so the majority of you chose B, CT head without contrast. So what did this girl have? Cerebral edema? Well, she might have cerebral edema. And the mom had something like this also. And so she's on birth control pills. So anytime there's a female on birth control pills or who's pregnant, you should always try to rule out venous thrombosis. That's a very important thing that you need to rule out. So she had this CT of her head, and so we see the veins coming in here, the sinuses, right? On this side, it's nice and patent, and on this side, there's a complete cutoff over here, so we don't see the vasculature on this side. So she had a venous thrombosis. So anytime somebody has a new onset, very bad headache, and if they're pregnant, when I see a patient who's pregnant with a headache, I get imaging to rule out a venous thrombosis because this is something which is emergent and should not be missed. So very frequently, they'll present with headaches, but also they can have seizures, they can have vomiting, and they can say that it's, a very bad headache. They can sometimes be visibly in pain. Dehydration is something that can predispose them to venous thrombosis. And so an MRI and an MRV, so MR venogram, is the best diagnostic tool. So that kind of maps out the whole venous system within the brain. And so how do we treat it? There's controversies in how we treat it. So we usually do some kind of anticoagulation that depends on what's being done in your center, but you want to rehydrate. You want to kind of minimize the other things which could be aggravating the system. So you want to rehydrate, give infection management if needed, and give anticoagulation. All right, and we'll talk about some trauma. So the number one cause of child death is accidents, mostly with head injuries. And so skull fractures occurs a little bit more frequently in males. 80% of them are linear skull fractures, so it kind of follows a line. Sometimes there can be a ping pong fracture, so that's sometimes people call it a table tennis fracture. And so what happens is if you've seen a ping pong ball, when they get those dents in them and you can't play because it kind of wobbles to one side, and then you try to use your finger and pop out that dent, and you can sometimes make it smaller, but it's really difficult to get that dent out. So those are called ping pong fractures, when the skull actually kind of indents like that. And you can see right here, there's a little bit of an indentation here on this X-ray. So after getting the X-ray and you see it, you can do further imaging with a CT if there's a depressed skull fracture, if there's any alteration of consciousness or awareness lasting for more than 5 minutes, if there's any seizures or any other focal neurological signs, if they're less than 6 months. So anytime we have somebody who presents to the ER who's less than 6 months, the way that we look at them should be a little bit different, because when we have an infection in less than 6 months, if they come in with a fever, most of the time they'll get a very serious workup. They'll get a lumbar puncture, they'll get other blood work to make sure that they don't have a meningitis. So likewise with imaging, if there's a fracture in less than 6 months, you should take it very seriously. If there's bulging fontanelle, you'd want to do imaging and see why the fontanelle are bulging, or if there's persistent vomiting. And skull fractures at the base of the skull can present with a couple different scenarios. So one is raccoon eyes, so they can have this darkening here like a raccoon, so right in here or right around the eyes. There's battle sign, which is basically darkening on the mastoid bone here behind the ear. And CSF can also leak from the nose or the ears. These are all signs of a basilar skull fracture. All right, and so we already mentioned when to do the CT when we suspect a skull fracture. The basilar skull fracture is by far the most concerning, because in that basilar region of the brain, which is in the lower part of the head, it's a very crowded space, right? We have the posterior fossa, we have the foramen magnum. So if there's something going on there can be some swelling, and it doesn't take a lot of swelling to compress various structures in that area. So with a basilar skull fracture, you'd want to observe very closely for signs of decompensation. And with trauma, there can sometimes be axonal injuries. So that usually happens with some kind of acceleration/deceleration injury, most commonly with motor vehicle accidents, or any time that they're moving with momentum and then suddenly stop. It can cause shearing of blood vessels, of the white matter of the brain. You can do an MRI to confirm it. And a lot of times they'll present with alteration of their awareness, of their consciousness. They can have decreased cognition. And so what we'll do, there's not a whole lot once the white matter has been sheared, but you want to make sure that the blood vessels have not been injured also. So you'd want to do some imaging to make sure the blood vessels are intact, and give supportive care as needed. All right, and so an epidural hematoma. So I used to always confuse epidurals and subdurals. And epidural looks like this. It's lens-shaped. And basically what happens is the dura is kind of stuck to the inside of the skull bone. And so if there's blood accumulating there, it will still remain attached to the skull everywhere that there's not blood. And so basically there's this layer right here of the dura, which is kind of being ballooned outwards by the blood. And so it's lens-shaped. It's this convex lens here. And so the way that I remember it now is epidural starts with an E, and the eyeball, starts with E. So it's lens-shaped like the eye. So that's how I remember epidural, and it's kind of lens-shaped like that. It's usually due to a temporal bone fracture, which can disturb the middle meningeal artery. It can cause tearing and blood accumulation thereafter. Very frequently with an epidural hematoma, they can have a lucid interval. So sometimes people will be involved in a car accident, they'll hit their head, and they'll get out of the car, think that everything is fine, they'll walk, talk, and die. And so that's how I remember it. It's a walk, talk, and die syndrome. And there was actually a famous musician who was hit by a car in Paris, and he had an epidural. And he went to the emergency room in Paris, and they had him waiting in the waiting room for 5 or 6 hours, and he finally said, "This is ridiculous, I'm fine, I'm totally fine, I'm gonna leave." And he left, and 2 hours later he was dead. He had an epidural hematoma. So it's very important to kind of monitor these people very closely, get some imaging to make sure that there's no blood accumulation. All right, and so it's always good to recognize herniation. Because herniation is something, once it's kind of set into place and this process of herniation is starting, it's very difficult to stop it. So it'll start very subtly with one pupil being dilated. And I've seen cases in the ICU after injury of some sort where the neurosurgery residents will come in and round at 4 in the morning, and then the peds residents will come in at 6:30 or 7 in the morning to round, and the peds resident will notice that one eye is not responding as well as the other eye, and the neurosurgery resident didn't see it. It wasn't there at that time. And then the peds resident will be rushing to finish their pre-rounds before their ICU rounds start, and then when they're presenting an hour later, they'll say, there was some abnormalities in the pupil, and then everybody rushes to check, and then they call neurosurgery because now both eyes are not responding anymore. So I've seen a case like that, actually. So if you notice an abnormality in the pupil, it's good to document it and try to figure out why it could be abnormal. Especially after trauma, it would be good to call neurosurgery right away. So if there's, in the initial stages, one eye will be affected, and as the herniation continues and gets worse, both eyes can be affected. There can be hemiplegia. There can be a third nerve palsy. So the third nerve, if it's not working, it'll make the eyeball. So if you have the two eyeballs, the affected eye will just kind of be hanging out down and out. So it'll be kind of looking down and out. And then later on, once things get very affected and the brainstem starts getting compressed, it can cause abnormalities in respirations, and they can have irregular respirations. They'll go into coma, and then thereafter they could potentially die. So it's good to call neurosurgery right away. All right, and then a subdural hemorrhage. So this is, unlike the epidural, which was kind of like this shaped, this is a crescent-shaped hemorrhage. And we see this sometimes in infants after non-accidental trauma. It can also be seen in scenarios where there's a meningitis. These patients will do usually a little bit better than an epidural hemorrhage. They can recover better than the epidurals will. All right, our next scenario, we have a 10-year-old child who was brought in after being hit in the head with a hockey puck. He was not wearing a helmet. Mother reports that he initially seemed fine, but he has since become lethargic. On examination, you notice that he is difficult to arouse, has begun to posture, and one pupil is much larger than the other. What might you find on CT? A, subdural hemorrhage, B, intraparenchymal hemorrhage, C, subgaleal hemorrhage, D, epidural hemorrhage, or E, intraventricular hemorrhage? All right, and the majority of you chose an epidural hemorrhage, so that's very true. So he is hopefully not having walk, talk, and die syndrome, but he's having walk and talk, but he's getting lethargic now. So he was struck with a hockey puck, and he was initially fine, but now he's slowly deteriorating. One pupil is not responding like the other one is, so there's evidence that he's kind of heading in that direction where the brainstem might be kind of coming downwards. So this would be an emergency case. You would want to take him to the operating room really quickly and relieve that pressure. All right, and we'll talk a little bit about spinal cord injuries. So in neonates, spinal cord injuries can occur, but it's usually secondary to birth-related trauma. So sometimes the baby delivers with the head, but the body gets stuck, and so they don't have a whole lot to pull, so they sometimes can pull the head, and that can cause a traction injury to the spinal cord. In older kids, very frequently it's other trauma-related, so from falling from a height, from diving into a shallow pool, or with motor vehicle accidents. So in the acute stage of a spinal cord injury, you can have areflexia, you can have paraplegia, quadriplegia, there can be flaccidity, sensory level, and some autonomic dysregulations. So their blood pressure can be difficult to maintain, they can go into shock. In later stages, they can eventually develop spasticity and hyperreflexia. So initially they can be areflexic or hyporeflexic, and then later they can develop hyperreflexia. This is also a neurological emergency, and steroid use in such a setting is a little bit controversial. It depends on what they're doing in your center. So the boards will not ask you controversial topics, so you don't need to know that, but it's always good to call neurosurgery right away when you suspect a spinal cord injury, and then they can determine if they want to do steroids or not. Let's do peripheral nerves, everybody's favorite topic. All right, so we'll start with brachial plexus injuries. So most commonly, this occurs in the birthing process. So if there's a shoulder dystocia, so if the shoulder gets stuck on the way out, and they kind of have to angulate and pull the child's head. So the brachial plexus, if you remember, it's coming out of the cervical spine, and it kind of goes from the neck here and kind of goes down into the shoulder area. It's the most common pediatric peripheral nerve injury, and it's associated with large babies, maternal gestational diabetes, which can produce large babies, forceps use, shoulder dystocia. Most commonly, most of the kids will make a full recovery. It just takes some time. And as I mentioned, I'm a big fan of PT and OT, so I refer all my patients who may have any kind of birth-related trauma related to the brachial plexus. I send them all for physical therapy because I think that it helps speed up recovery. And so here's the brachial plexus. And so here in the neck, this somewhere along here is where the stretching usually occurs. So if that neck gets stretched out, it can stretch out that upper trunk of the brachial plexus right here. And that's usually the nerve that's most often injured, and that can cause a Erb's palsy, or also called Erb Duchenne. And so this is that waiter's tip. So the arm will be internally rotated, and the hand will be pronated. And so what's the difference between pronation and supination? Pronation is like this, supination is up. So supination, the way I remember it, if you're holding a bowl of soup, your hand's gonna be up like this. Whereas pronation, if you're pro-Trump or pro-Hillary, your hand is facing down as you're doing the pro sign. Or if you're fist bumping, if you're fist bumping Trump, your hand will be down like that. That's how I remember it. A lot of times the shoulders will be sagging on that side, so if it'll kind of be like this, and the reflexes will be absent on that side. Most cases, 90% will recover within 3 months, but as I said, I like to do the physical therapy to help them recover. And if by the 3rd month they're not showing signs of recovery, I send them to neurosurgery so they can determine if surgical intervention is needed. And so what they can do is they can graft a nerve from somewhere else and kind of transplant it, and hopefully they can regain movement in that limb again. The other one that we less commonly see is Klumpke's paralysis, or also called Dejerine-Klumpke paralysis. This is of the lower cord, so this is C8T1. The previous one, herbs, was of C5, C6. This is less common, and sensory involvement can occur. And associated with this, because it's in the lower trunk, which is in closer proximity to a lot of the sympathetic plexuses, there can be Horner syndrome. So Horner syndrome is a triad of ptosis, meiosis, and anhidrosis. So what is ptosis? Ptosis is drooping of the eyelids, and it's usually on one side. I'm simulating both sides, but it's usually on one side. So ptosis, meiosis is small pupils, and anhidrosis is decreased sweating on that side of the face. So ptosis, meiosis, anhidrosis. It can affect the flexors and the extensors, specifically of the intrinsic muscles of the hand, so it can cause that claw hand appearance. And this one recovers within 3 to 6 months usually. The improvement for this one is not as great as with Erb's palsy, but improvement can occur, usually a little bit longer than it takes for the Erbs to improve. All right, and so we have sciatic nerve injuries. This can occur if we were to give intramuscular injections in the gluteal area. That's why we usually give injections in the deltoid or in the anterior thigh. So they can have a foot drop, so they can have kind of loss of tone of their foot, and so they might walk with a slapping gait, so the foot might kind of slap on the ground. They can lose their ankle jerk reflex, and they can have loss of sensation below the knee, or even distal to that. All right, we're going to talk about seizures. So seizures can be common at various ages. So there's a bimodal distribution of seizures. There's one peak in early age and one peak in later age, so in neonates and in elderly. So when we see somebody with a seizure, we want to know, is it a provoked seizure or is it a non-provoked seizure? So a provoked seizure would be a seizure that occurs in the setting of an illness or a setting of trauma or a metabolic condition which caused the person to have a seizure. So if it's an unprovoked seizure, then we don't find any reason for it and they just had a seizure. So those are unprovoked, and those are a little bit more difficult to treat and to get under control. So a provoked seizure doesn't necessarily lead to epilepsy. So what is epilepsy? Epilepsy is recurrent, unprovoked seizures. With epilepsy, there'll be recurrent seizures. The frequency of the seizures depends on what type of epilepsy they have or where it's coming from. And it's not that common. Roughly 1% of the population has epilepsy. But it all really is going to depend on, is it provoked or unprovoked? All right, and so once we determine is it provoked or unprovoked, we want to see then, if it's unprovoked, we want to see is it a generalized or a focal seizure. So generalized seizures can be of a few different types. There can be generalized tonic-clonic, so that's where the body is stiff, which is the tonic part, and clonic is shaking, so stiff and shaking, right? Myoclonic seizures, myo means muscle and clonic means movement. So myoclonic is where there's sudden twitches, there can be random jerks of the body. Valproic acid is a great medicine to treat myoclonic seizures. And we'll talk a little bit about valproic acid a little bit later. For absence seizures, that's another type of generalized epilepsy. So when I say generalized, I mean the seizure is coming from the whole brain at the same time. And so this can be treated very well with ethosuximide. And ethosuximide actually is only used for absence seizures. It doesn't work for any other type of seizures. So if you have absence seizures, ethosuximide is the way to go. There's other medications. Valproic acid can work also, but ethosuximide is usually the first medication that we use. And absence seizures can be brought on by hyperventilation. So when we bring in kids to do an EEG, we'll have them blow on a pinwheel or something like that to make them hyperventilate, and we'll see if we can make them have an absence seizure. And then two other types of generalized seizures are tonic and atonic seizures. So tonic means they're stiffening, and atonic means that they're losing all the tone in their body and they can just kind of drop to the ground. So those are also generalized seizures. So here we'll watch the video really quick.
Hey, look what I got. Jay, look over here. Look, Fat Daddy.
So in this video, we see the patient's eyes are off to the right.
Look, Fat Man. Look.
And
Look what I got.
there was one point where I saw his lips kind of move a little bit. There we go. There's some lip movements.
Look, Fat Daddy.
And so this is a focal seizure. So with focal seizures, they can very frequently have eye or head version. Version meaning turning to one side. So they can have head or eye version to one side. And they can very frequently have... I'm going to stop the video. They can have simple or complex. So we'll talk a little bit about the difference between simple and complex. And they've come up with these new classifications of seizures. They changed it in 2010. They've now changed it in 2017. So now they use more descriptive terms. So they want to know, is it motor versus non-motor? So are there movements, or is it just kind of an alteration of awareness? Is awareness impaired, or is it intact? And what we previously used to call secondary generalization is now called focal seizure, which progresses to bilateral tonic-clonic movements. It all means the same thing, but they've just come up with this new classification for it. So with simple partial seizures, there's no alteration of awareness. So the awareness, if it's maintained, that will define whether it's simple or complex. There can be motor or sensory or version. I mentioned the head or the eyes with version to one side. Typically, these last for about 10 to 20 seconds in duration. They can have an aura. So an aura is a warning sign, so they can sometimes know that their seizure is coming. And they typically don't have a post-ictal confusion. So post-ictal means... Post means after, ictal means event. So post-ictal means after the seizure. They don't typically have the post-ictal confusion because their awareness is maintained during the seizure. With a complex partial seizure, they have an alteration of their consciousness or awareness. There will be that post-ictal confusion very often. They can have a warning sign, that aura. They can also have automatisms, so they can have like lip smacking movements. They can have fumbling around with their hands. They can kind of pick at their clothes. And complex partial seizures are a little bit more difficult to treat and get under control. And very frequently, when we have a focal seizure, it's good to do an MRI. With generalized seizures, you don't have to do an MRI. But with focal seizures, you definitely should, because you want to look for, why is it coming from one side of the brain? We want to see, is there something like this? This is called mesial temporal sclerosis. So this is the temporal lobe of the brain, and this is the mesial or the medial part of the temporal lobe. And sclerosis basically means like a scar. So there's scarring in that mesial temporal lobe. And that is very frequently a region of the brain where seizures can arise from. And now what we've started to do is we can actually map out to see, are all the seizures coming from this one area? And we can work with the neurosurgeons to go in and actually resect that area and try to make the patient seizure-free. So we're starting to do a lot more epilepsy surgeries to make people seizure-free. All right, another video. All right, we'll play it again. Did you see what we need to see? Right there. One more time. All right, and I don't know if I can shut it off or not. So we're just going to listen to that as I talk. So this patient actually presented with these spasms, and this is my patient actually. So the mom called me up. I was seeing him because he had had other complications, and the mom called me up one day and said, he's doing these weird things where he'll just kind of flex his body up really quickly. And I thought, oh no, this is not good, because he actually had a stroke at 6 weeks of age, secondary to RSV bronchiolitis. He coded for about 30 to 40 minutes, and they were about to pronounce him. But then he went on ECMO, and there's a long history that goes along with it. But anytime somebody, a baby, has an injury to their brain, it can predispose them to have seizures and infantile spasms. So when the mom called and said, he's doing this weird thing, I was like, no, this is not good. So I said, okay, I want you to bring him in for an EEG tomorrow. And this is his EEG, actually, that he came in for the next day. And he had one of those on his EEG. And the EEG correlated with this and showed this pattern called hypsarrhythmia, where it's a very high voltage, chaotic pattern. There's no rhyme or reason about it. It's just very ugly and chaotic looking. And this is called infantile spasms. And it can occur, most of the time we don't have a reason as to why it happens. We look, but we don't always find a reason. And it's better to not have a reason. That means that it's more likely we'll get it under control with medications. And so very frequently they'll have these spasms like he keeps showing you, and they can cluster. So he'll have one, and then he'll have another one, and then another one. And they're very frequently, they're called salam poses, because basically he kind of flexes the body forward, and they can have like kind of stiffening of the arms and legs, of the extremities. And so the treatment for infantile spasms is usually some kind of steroid therapy. So it's controversial depending on which center you train at or which center you're working at, if they use ACTH versus prednisolone. Both have been proven to be effective, but you should use some kind of steroid therapy. So if you get this question on your boards, your first choice should be a steroid therapy. You can also use vigabatrin, but vigabatrin is used for when there's infantile spasms with tuberous sclerosis. So it works really well for people who have tuberous sclerosis who develop infantile spasms. The main side effect of the vigabatrin, though, is that they can have a loss of their peripheral vision, which is permanent. So we have to monitor it very closely, and a lot of people are not comfortable using it because of that potential peripheral vision loss. Infantile spasms, in my opinion, should be treated very urgently, so we should start treatment on it very soon. The earlier treatment is started, the potentially better the outcome could be. So I usually try not to waste time. I talk to the parents right away about what it is, and I start treatment. There's something called West syndrome, which is a triad of infantile spasms, developmental delay, and that pattern of hypsarrhythmia, which I told you about. So not all infantile spasms is going to have developmental delay, but if it starts progressing and it goes untreated for a long time, then there's more of a potential for it to go into West syndrome. All right, and gelastic seizures, this is when people will have inappropriate laughter associated with their seizures. So they'll just randomly start laughing for no reason, and it correlates with a lesion in the hypothalamus, and most frequently, it's a hypothalamic hamartoma. So it's a kind of a benign tumor within the hypothalamus. And very frequently, the surgeons can go in and take out that tumor, and they can become seizure-free. All right, so the treatment of epilepsy, so as I mentioned, when you're evaluating epilepsy and seizures, not everybody in childhood needs an MRI. And MRIs are a little bit tough in kids, right? Because in order to achieve an MRI in the younger kids, we have to give them anesthesia. So the way that I do it is I think to myself, if this was my child, would I put them through anesthesia to get an MRI? Sometimes the answer is yes, but a lot of times it's no. So I try not to do unnecessary MRIs just for the sake of not doing general anesthesia. But having said that, if they need it, I don't hesitate and I explain to them that anesthesia would need to be used. An EEG should be done in all people who have a suspected seizure or a definite seizure. And a lot of times, if on an EEG we see something focal, then I go for an MRI. But in generalized epilepsies, in childhood, they're usually a little bit more benign in the sense that they grow out of them. Focal seizures are a little bit more difficult to grow out of. So focal seizures, you want to make sure that there's nothing like that scarring, that mesial temporal sclerosis that we discussed. You should educate all of the parents and the families about seizures. So what I tell them is no unsupervised swimming, no unsupervised climbing heights, no unsupervised, don't let them sleep on a top bunk. So basically anything that if they were to have a seizure, they wouldn't injure themselves or harm themselves. We had in my city 2 weeks ago, we had a girl whose father is a physician. She had a seizure underwater. She was at the beach and she died actually. So even though the father is responsible, he's a doctor and everything, it can still happen. So it's very heartbreaking when something like that happens. So no unsupervised swimming. And I also tell my patients, don't lock the door in the shower. We had another patient who had a seizure in the shower, and she fell forward and turned the water to the hot side and ended up burning herself in the shower. So it's good. And as she was doing that, the family is breaking down the door to get to her. So it's all basically safety precautions. So if your patients have a seizure, somebody can get to them and help them. All right, now that I've thoroughly depressed you all, let's move on. All right, so there are certain medications which are better for certain types of epilepsies. I'll just talk about a couple of these. So for absence seizures, I told you that ethosuximide was the best way to start. If ethosuximide doesn't work or they have significant side effects, you can move to something like valproic acid or lamotrigine, which also can be helpful, but usually ethosuximide is the best at controlling them. For the infantile spasms, the first line would be the ACTH or the prednisolone, and you can use the vigabatrin when there is tuberous sclerosis. That's what the TS stands for. There are certain medications which can work for both focal and generalized seizures. Valproic acid and levetiracetam are two of them. And carbamazepine only works for focal seizures. All right, and phenytoin is a medication which used to be used a lot for all ages, and then we started to get all these newer medications, so we've gotten away from using phenytoin. Phenytoin is a very good medicine for seizures, but because of all the side effects, we don't use it chronically in kids. Having said that, we use it in status epilepticus if we need to load a patient with medication to help control their seizures. But if they're going to need a long-term medication, phenytoin is not one that we typically use. So it can cause hirsutism, it can cause that gingival hyperplasia, the overgrowth of the gums. It can cause a very significant rash, like a Stevens-Johnson's rash. It can affect the liver, cause thrombocytopenia, leukopenia. It can be teratogenic. So it's not an ideal medicine, but in board exams and PEDS boards and neuro boards, they like to ask about it because side effects don't change, and it has this zero order kinetics. So you can load it, you can check levels, and then you can actually kind of predict how the level is going to decrease over the next couple of days because there's a constant rate of elimination. So that's something worth remembering also. All right, we'll talk about a couple other medications and their side effects. So with carbamazepine and its kind of sibling medication, oxcarbazepine, which is a newer version of it, it can cause hyponatremia. So on patients who are taking those medications, you have to check the sodium levels. Oxcarbazepine doesn't cause the sodium to drop as much as the carbazepine does. Valproic acid is a very nice medication for different types of epilepsies, but we don't use it in all people. So it can cause polycystic ovaries and birth defects. So we try not to use it in females once they've reached menarche. So after they've started their menses, it's not an ideal medication to use. It can also cause weight gain, loss of hair, acne, so a lot of cosmetic effects, which I don't think anybody would really want. It can also cause leukopenia, thrombocytopenia. It can affect the liver. So there's a lot of blood work that's going to be needed if a patient is taking valproic acid. Lamotrigine is very infamous for causing a Stevens-Johnson's rash. So when we're going to use lamotrigine, We start at a very small dose, and every 2 weeks we build it up, and it takes usually about 2 to 3 months to get to a desired drug level. So it's not the kind of medication which is going to help us today or tomorrow. It takes several weeks to build it up. All anti-epileptic medications can potentially cause depression, suicidal ideation. So there's kind of a black box warning for that. Stevens-Johnson's rash associated with lamotrigine has a black box warning. So I always counsel my patients that when we start any kind of medication which has effects in the brain, it can cause sadness, it can cause aggression, so different kinds of behavior changes. And I tell them if they start to develop any significant sadness or concerns for hurting themselves or others, they need to call me right away and stop the medication. All right, and so status epilepticus is a prolonged seizure, usually for at least 5 minutes in duration. And it could be also multiple seizures back to back without regaining consciousness. It can be seen in sepsis, meningitis, after trauma, and sometimes it can be unprovoked. They can have convulsive, non-convulsive. So non-convulsive would be where we just see it on the EEG and we don't see any clinical signs. It can be partial, so located on one side of the body or in one limb, or it can be generalized. So how do we treat it? So as with anything, we want to make sure they're breathing appropriately, their circulation is appropriate, so do the ABCs as you normally would. Always check electrolytes, blood glucose, because hypoglycemia can cause seizures. If there's any kind of electrolyte imbalance, you want to correct that. Make sure that they're breathing well, their blood pressure is stable, they don't have any fevers. So the first line treatment is benzodiazepines of some kind or other. So usually in the emergency room setting, we use something like a lorazepam, or we can use midazolam, which now comes in those intranasal puffers. So a lot of EMS personnel will carry intranasal midazolam, or they'll have diastat, which is diazepam, in the ambulance, and they can give that in the field. After benzodiazepines, if it doesn't work, we usually hit them 2 to 3 times with benzodiazepines, and then if the seizure does not stop, we move to loading them with another medication. Usually that's going to be either the fosphenytoin or phenobarbital. Pentobarbital coma is listed on here. It's not meant to be the third line agent. It's kind of an end of the line. That's kind of like a last resort. If you can't get the seizure to stop with the fosphenytoin and with phenobarbital, sometimes we use valproic acid or levetiracetam also to load. But eventually we might have to get them into a pentobarbital coma to stop the seizures. So very frequently, our patients will ask us about when can we stop seizure medications? And the answer to that is a little bit tricky. It depends on how controlled the seizures are. So they need to be seizure-free on medications for at least 2 years. So it's 2 years seizure freedom with a normal EEG. If the EEG remains abnormal, but they're not having clinical seizures, they need to be treated for 4 years. And a lot of times what will happen is we'll get a patient, a teenager or something, who will say, I haven't had a seizure in a year, I'm cured, and they stop their medicine. And what happens? They have a seizure. So then I very politely remind them that they can no longer drive, because depending on which state you live in, there are rules for driving in epilepsy. And so in my state, they have to be seizure-free for a year. So if they've had a seizure and they're at driving age, then they can no longer drive for a year, a minimum of a year, if they remain seizure-free. So it's always good to keep driving in mind when counseling people about epilepsy. We don't always treat after a first-time seizure. So anyone could have a seizure. I could have a seizure, any of you could have a seizure. It doesn't necessarily mean that we're going to have a second seizure. After we've seen a second seizure and we determine that they have a tendency to have further seizures, that's when we would start thinking about starting a seizure medication. If they have a very abnormal EEG after the first one and we predict that they could have more seizures, then we might want to think about seizures. But typically, we don't have to start a seizure medicine after a first-time seizure. Let's see. When starting seizure medications, you want to keep the side effects in mind. So sometimes you can tailor medications to work in the patient's favor. For example, topiramate can cause weight loss. So in overweight patients, topiramate might be a way to go to help lose some weight. And alternatively, valproic acid can cause weight gain. So sometimes in my very thin patients, I might put them on valproic acid to control the seizures, and hopefully they gain some weight in the process. So it's always good to keep side effects in mind also. And so another question that I get asked is, can moms who are on seizure medications breastfeed? And so the answer to that is yes, they can. Having said that, though, certain things can cross into the breast milk, but is it better to not breastfeed because of that risk, or is it better to breastfeed? And so the American Academy of Pediatrics has ruled that it is better to continue breastfeeding rather than to not breastfeed in such a scenario. So the answer is that we should always encourage breastfeeding. Some anti-epileptic medications can affect the P450 system, so they can change how effective oral contraceptives might be. So that's something that if you have a patient who you're going to be putting on oral contraceptives and they're already on an anti-epileptic medication or vice versa, then you would want to make sure that it doesn't affect the effectiveness of the oral contraceptive. Neonatal seizures. So most commonly, seizures that occur within the first 24 hours of life are due to hypoxic ischemic encephalopathy. So some kind of scenario where there was a potential decreased oxygenation going to the brain. So this can be related to birth trauma, some kind of infectious process like an HSV infection, some kind of intraventricular hemorrhage that can also cause ischemia to the brain, other malformations, chromosomal abnormalities. So these are all things that can potentially cause neonatal seizures. When seizures are seen in the first couple days of life, very frequently we'll see a whole lot of seizures right away, and then we don't see a lot of seizures after that. Sometimes. Sometimes they can have very difficult to control seizures into childhood, but very frequently, if it's just something like hypoxic ischemic encephalopathy and they have neonatal seizures within the first 24 hours of life, they frequently do very well and they don't need to be on long-term anti-epileptic medications. All right, and so febrile seizures is actually very common. So the way that I think about it is it's seen in roughly 1 out of 25 kids. So 25 kids is kind of like an elementary school class. You know, most classes have about maybe 20, 25 kids in them. So it's possible that one of those kids will have had or will have a seizure, a febrile seizure at some point. It very frequently runs in families. So when I see a patient, I'll ask the parents, did either of you have a febrile seizure? And sometimes, dad had one or mom had one in childhood. And very frequently they grow out of them. We don't typically treat febrile seizures, but often we can give the patients diazepam, rectal diazepam, to abort a long seizure. So if the seizure is going on 5 minutes, we can give them that rescue medicine to help stop the seizure. So there are simple febrile seizures and complex febrile seizures, and there's a few things that help define these two things. So a simple febrile seizure is going to be less than 15 minutes in duration. It's going to be a generalized seizure, so the whole body is shaking, so it's not going to be focal. If it's just one side shaking, that's going to be a complex febrile seizure, and they only have one within 24 hours. So if they have more than one, that now makes them a complex febrile seizure. And complex febrile seizures are also longer than 15 minutes in duration. And very frequently, as I'm sure you all know, that daycare kids get infections more frequently, have fevers more frequently, so they can also sometimes have febrile seizures more frequently. So we don't get EEGs on every febrile seizure. It's if there's concerns about something very specific, then we can get them. But very frequently, in the past, when my group has gotten EEGs, or sometimes the ER will just order an EEG when the kid is getting admitted, and we'll see some slowing on one side. So what does that mean? Is the slowing a true problem in the brain, or is it still a post-ictal slowing? So after a seizure, you can have some slowing in the brain. And so then we don't know what to do with it. Do they have a true abnormality or do they not? So do we put them on medicines or do we not? So we have problems then that come up from doing unnecessary tests. So the American Academy of Pediatrics says that you should not do an EEG for a simple febrile seizure, a first-time febrile seizure. You don't have to do blood work, you don't have to do imaging, and you don't need to put them on anti-epileptic medications. You educate them, you tell them that this is what you do if a seizure occurs, you make sure that they're safe, you roll them onto one side, so if they're drooling, they don't choke on the drool, it comes out rather than in, and you don't put anything in the mouth, so an old wives' tale from previous years was that you put a spoon in the mouth to push down the tongue so they don't choke on the tongue. So we don't actually believe that anymore. And I've had some people tell me that the mom has stuck her finger in the kid's mouth to push the tongue down, in place of a spoon. That's not good either, because when people have a seizure, they can bite down with such force that they can actually chop off mom's finger. So that's not good. So tell them, don't put anything in the mouth, roll them onto the side, and most seizures stop within 2 to 3 minutes. Do febrile seizures need a lumbar puncture? Not always. So if there's meningeal signs, so if they have that neck stiffness, if their immunization status is not known, if they have a partially treated infection, then you might want to think about doing a lumbar puncture. But most febrile seizures do not need a lumbar puncture. All right, we have another scenario here. A 6-year-old, previously healthy boy brought to the urgent care clinic because he experienced a spell consisting of eye deviation to the right, inability to talk, drooling, and perioral cyanosis, with a period of confusion thereafter. He's back to baseline, and neurological examination, including a fundus exam, is normal with no focal weakness. Which of the following is the best initial step in treatment? A, educate the family regarding seizure precautions. B, start an anti-epileptic drug while you wait for a neuroconsult. C, order a CT head without contrast. D, order an urgent EEG. E, obtain CBC and electrolytes, including calcium, magnesium, and phosphorus. All right, so we're a little bit torn between what to do, but the majority of people chose the correct answer, which is A, educate the family regarding seizure precautions. So let's go down these choices here. So nobody chose B, so we don't start an anti-epileptic medication after a first-time episode, okay. C, order a head CT. We don't need to typically order imaging after a first-time seizure. Did we all know it was a seizure? Yes? Did anyone think it was anything else? No? Okay. All right. So we don't need imaging. We don't need an urgent EEG. We could get an EEG down the road, but it doesn't need to be urgent. So you have to pay attention to the language. It's saying what's the best initial step in treatment. So EEG could be done, but not an urgent EEG. And we don't typically need blood work either. So the best initial step is educate the family, seizure precautions, and then you can send them to neuro or EEG or whatever if you need to, if there's a suspicion down the road. But initial step is education. All right, an 18-month-old previously healthy boy is brought into the clinic with a history of having had a 3-minute generalized convulsion at home. He is febrile, temperature is 103.1 or 39.5 Celsius, but he has a normal neurological exam. There is no neck stiffness, and he appears alert and interactive. Father had a history of seizures with febrile illnesses as a child, but is now healthy. This is the child's first seizure. which of the following is the best initial step in the workup or treatment of the seizure? A, obtain CSF for analysis. B, obtain a CT head. C, obtain MRI of the brain. D, prescribe diazepam by mouth for PRN use if he should become febrile in the future. And E, reassure the family that he will probably outgrow the events. All right, so I think we all mostly agree on that one. Diazepam by mouth. So the first time I read this scenario, I was like, hey, diazepam by mouth, okay, yeah, let's choose it. But we don't do any medication by mouth when somebody's having a seizure. That was a trick question because you probably read it, but you missed the by mouth part, which is what happened when I first read that scenario. So yes, I can get some of these wrong too. So if it was diazepam rectally, then it would be like, I don't know what to choose. But by mouth, we don't give them anything by mouth unless it's something that dissolves on their tongue. But we don't want them to choke on an oral medication. So that's why we wouldn't use the diazepam by mouth. All right, so there are paroxysmal spells, which we can see in people. So we'll kind of go through the different paroxysms that we can see according to age. So less than 2 years of age, they can have apneas. So we get lots of consults from our NICU, our neonatal unit, for apneas and bradycardias, and sometimes they're seizures, but a lot of times they're not. But because they're having these spells, we get an EEG to try to correlate, does the EEG correlate with the spells or not? Reflux is a medication, a scenario where they can also have significant stiffening of the body, and it can actually look like a seizure sometimes. That's called Sandifer's syndrome. And so what'll happen is they'll have reflux. And what happens if one of us has reflux? It burns, we kind of stiffen up, we kind of do these movements. So babies, when they have one of these episodes, they'll arch their back, their face will turn red, they'll stiffen up their whole body, they'll shake a little bit, and it can actually look like a seizure. I've seen one of these in the ER one time, and I was like, wow, that's a seizure. And then we'll capture one on EEG, and I'll say, whoa, I was wrong. It was not a seizure. So they can look like seizures. There can be infantile spasms, also jitteriness in that infantile age. Infantile spasms, I forgot to mention, it usually occurs less than a year of age and most commonly between 5 and 7 months of age. Between 2 to 5 years, they can have breath-holding spells. They can have other self-stimulatory behaviors, night terrors, and other types of seizures. And school-age kids can have daydreaming, which we see a lot. I get a lot of referrals for kids who are zoning out in school, which I do all the time. If you ask my wife, she'll tell you that I zone out when she's talking to me. So that's a common thing, I think, in guys. So daydreaming spells, nightmares, other types of tics, and other movements are various paroxysms we can see in older kids. All right, we're going to talk about headaches and migraines. So how do we define a migraine? So the International Headache Society has given us a classification for headache disorders. So to define a pediatric migraine without aura, they have to have had at least 5 attacks with all these features. So they have to have had a headache lasting for at least 2 hours and less than 72 hours. They have to have had a headache with at least 2 of these 4 features. So bilateral or unilateral in the frontal or temporal regions, pulsating in quality. So I'll ask my patients, does your headache go boom, boom, boom? And that would define a pulsating headache. And is it aggravated by physical exertion? So I'll ask them if they're in gym class, do their headaches get worse? And they also have to have one of the following under C. Nausea or vomiting, nausea and or vomiting, or photophobia and or phonophobia. And so, that's sensitivity to light or sound. And so how do we treat headaches and migraines? So I tell all of my patients to keep a headache diary because it's very commonly things that are within our day-to-day life and lifestyle, which can be a trigger for our headaches. And I can tell you that most of the people never do a headache diary, and they all come back to me and I'll say, "Where's that headache diary?" And they'll just be like, well, I didn't have paper at the time. And so I tell them to put it on their phone. I say you can either download an app or just put it in the notes section of your phone, but they don't do that either. So, but I still tell them do it anyways. I'll give you one example. I have a friend of mine who was in pediatrics residency with me. She came to me and said, "I need you to refer me to a neurologist." I'll say, "Okay, for what?" She said, "For migraines." And she didn't get into the details, so I sent her to one of my other friends, and he said he wanted to put her on all these medicines. She came back and said, "Send me to someone else." And I said, "Well, what's the problem?" And I went down her lifestyle, and I asked her, "Do you drink a lot of caffeine? Do you eat a lot of processed meats? Do you eat a lot of things with MSG, like ramen noodles, cup of soup, taco seasoning packets, Doritos, Cheetos? Do you eat a lot of chocolate?" And all of these things, she said, "Yes, that's like everything I live on." And so I said, "Stop all of these things," and her migraines went away completely. So it is very oftentimes things that we're eating or our sleep or eye strain. So it's something very frequently that's in our lifestyle which is causing headaches. So I'll kind of take that kind of history and very frequently in teenagers, it's skipping breakfast. And so just by eating breakfast, their headaches get much better. So it's very important to take a good history regarding their lifestyle. So triptans are abortive medications. So in order for that to be successful, the individual has to know when their headache is coming. So they have to have an aura. So sometimes they can feel something or other which tells them one of their really bad headaches is coming. So in that scenario, you can give them a triptan. So almotriptan can be used in teenagers. Rizatriptan can be used as young as 6 years of age. And a lot of times, giving it in combination with an NSAID can also actually help improve their headaches. And they have to take it at the very onset of their headaches. So it's not going to work if their migraine is already in full force. It needs to be taken at the onset, otherwise it won't work. For an average headache or typical headaches, you don't necessarily need to do imaging, but if there's unilateral headaches, always in one area, or if they're having early morning headaches, then you would want to consider getting imaging. So early morning headaches or headaches which wake up a person from sleep could indicate something which is causing an increased intracranial pressure. So for example, if there's a tumor or something else which is a mass within the brain, when they're laying in the recumbent position, due to gravity, there can be an increase in the fluid retention within that mass, and that can cause early morning headaches or headaches that can wake them up in the middle of the night. You'd also want to consider imaging if they have some kind of focal neurological abnormality, any episodes of alteration of their consciousness, or any sudden headaches. Where it just randomly comes out of nowhere, or if they're located in the occipital region or they occur with Valsalva. So here on this image, we have the normal ventricles here, right? But then there's an extra something or other here. We can't tell what exactly that is, but it's some kind of mass within the brain. So imaging, could be done, which could help to tell us what exactly that is. So we would want to give contrast. We would want to look at other images on this CT scan and see if we can further differentiate what this lesion is. And so giving prophylactic treatment for migraines, we typically do not do it for all migraines or headaches. If they're having frequent headaches, or if they're missing a lot of school, or if the headaches are very debilitating or very troublesome, then we talk about different options. And very frequently, as I mentioned earlier, I will try to help with the side effects in the patient's favor. So, for example, patients who are overweight, I might prescribe topiramate rather than something else that might cause them to gain weight. Cyproheptadine is a great medication for the younger kids. It can oftentimes help with sinus pressure and allergies and that kind of thing also. And the thing to keep in mind with cyproheptadine is it can cause some weight gain, so that would be something that you would need to monitor very closely. Amitriptyline is also a good medication for controlling headaches, but it can cause sedation, it can cause some EKG or irregularities, so a baseline EKG is very important when starting amitriptyline. Let's see. So there was a study done in 2017 which looked at giving amitriptyline versus topiramate versus a placebo in kids in 8 to 17 years of age. And what they found was that all of the kids who received something improved. The problem is that the placebo group improved the most. So what do? It's a lot of times it's the satisfaction of taking something which might help, but not always. I really think that a lot of medications can be very beneficial for people with chronic headaches and migraines. So next we're going to talk about pseudotumor cerebri or idiopathic intracranial hypertension. So this is a increased intracranial pressure without explanation. So we don't have a reason for it. So there'll be headache, oftentimes a significant headache. There'll be visual obscurations, so they can have loss of vision. They can have these shimmery sensations in their eyes. They can have sensitivity to light. They can have flashes of light. They can have ringing in their ears. They can actually sometimes hear their heartbeat in their ears. They can have retrobulbar pain, so pain behind the eyes. They can have diplopia, which is caused by a sixth nerve palsy. And very importantly, you should do a fundoscopic exam on these patients. That's why I stress the importance of a fundoscopic exam. An LP should be done in patients with pseudotumor, but you typically should get some kind of image ahead of time to make sure that there's no mass in the brain. Because if you do an LP on somebody who has a mass lesion or a space-occupying lesion, you can actually cause them to herniate their brainstem, and that is not good. So it's good to get a screening CT or an MRI to make sure that there's no mass lesion. And once all of that has been ruled out, you can do an LP, and you need to get an opening pressure. So after the needle is placed in, you put the manometer on and turn it on and see how high the water level goes. And benign intracranial hypertension is confirmed with a pressure greater than 25 millimeters of water. So once that's diagnosed, you can take out about 10 cc's of fluid, and that usually should resolve the headache, resolve their symptoms, and they'll do great afterwards. And then we send them home on acetazolamide. So acetazolamide works in a couple different ways. It's a diuretic, so you basically will urinate out extra fluid from the body, but it also works, it's a carbonic anhydrase inhibitor, so it helps to decrease the CSF production. So it works by getting rid of the extra fluid and by decreasing the production of the fluid. There are certain parts of the history which are also important when looking at intracranial hypertension. You want to make sure that they're not on a medication which can cause an increase in the pressure, such as tetracycline. Obesity could be a cause for intracranial hypertension, and oral contraceptive use. And smoking also can cause benign intracranial hypertension. It can also be associated with lupus, Addison's disease, obstructive sleep apnea. So weight loss is always very highly recommended for these patients if they're overweight. Acetazolamide is a medication which can also help to decrease the flare-ups, so long-term acetazolamide use. And in patients who are refractory to the acetazolamide, they can have optic nerve fenestration or a shunt placed, but those are surgical techniques which we don't go to right away. All right, a 16-year-old girl presents to the clinic complaining of diffuse bilateral pain in her head for the past year. She has no vomiting, nausea, or light or sound sensitivity. The pain is poorly responsive to ibuprofen. She admits to anxiety and depression. Her neurological examination is normal, including all her cranial nerves and fundus. Which of the following is the best initial step in her management? A, start a regimen of daily ibuprofen for the next few months. B, obtain a 24-hour EEG. C, obtain a CT head with and without contrast. D, prescribe oral sumatriptan. Or E, discuss headache hygiene topics and refer her for counseling services. All right, so most of us chose E, discuss headache hygiene topics and refer her for counseling. Let's see, somebody chose C, obtain a head CT with and without contrast. Head CT doesn't need to be done in all patients. If there's something very significant or if there's a unilateral headache, you could do a CT, but she was having bilateral pain for the past year, so it's not even a new headache. There's no nausea, no vomiting, there's no sensitivity to light or sound, and she kind of admits to anxiety and depression also. So anxiety and stress is a very big cause of headaches also. So in those patients, if a medication is needed, we talked about amitriptyline, which is a great medication for depression, so that can oftentimes be a medication which I'll use for such patients. All right, the next question, a 16-year-old girl with a history of long-standing migraine headaches presents to the ED with the worst headache she has ever experienced. On exam, she has neck stiffness, but has no focal deficits and no papilledema. On questioning, she states that the head pain started when she tried to lift a heavy bag. Which of the following is the most likely diagnosis? A, exacerbation of migraine, B, cluster headache, C, viral meningitis, D, meningoencephalitis, or E, subarachnoid hemorrhage. All right, so most people chose E, subarachnoid hemorrhage, which is the right answer. A, exacerbation of migraine, and B, cluster headache. C, I don't know, does 2% mean that somebody chose it? I assume so, right? So C, viral meningitis, E, meningoencephalitis. So let me tell you, in this patient, she has long-standing history of migraines. So yes, I could see how exacerbation of migraine could have been chosen, but now she has a sudden worsening of her pain, which started when she tried to lift a heavy bag. That was a very important part of the scenario. So she basically, something acutely happened. And of these, she didn't seem like she had any kind of illness. I can see how you would think there might be an illness with the neck stiffness, but neck stiffness can happen with a subarachnoid hemorrhage also. So that can be one of the signs of a subarachnoid hemorrhage. So it was a little bit tricky there. All right, so we'll talk about disorders of muscle. So in the peripheral nervous system, there's the anterior horn cell, there's the roots, there's nerves, there's the neuromuscular junction, and the muscle. And so some of the conditions which we see within the muscular system are spinal muscular atrophy, SMA. This is usually a very severe cause of muscular weakness, and it's usually not a good condition to have. Very frequently, kids can die within the first couple of years of life, depending on which type of spinal muscular atrophy they have. It is autosomal recessive. So genetic testing is available. You can do genetic testing and map out, for future kids, what their risk could be. It's an anterior horn cell disease, and it can cause hypotonia, it can cause weakness, and respiratory failure. And kids will usually die from their respiratory failure. It's usually a very slowly progressive illness, depending on which type they have. So if they have the type that where they develop symptoms in the infantile period, that's usually the more severe form of it, and they usually die within the first 2 years of life. There's an intermediate form, and there's a Kugelberg-Wiellander form also. And so these can have varying degrees of how affected the patient can be and what degree of respiratory compromise they'll have. There's a new medication which has been FDA approved for use for SMA called nusinersen. And so basically what happens with SMA is that they have defective SMA gene. And the nusinersen helps to kind of replenish that defective gene. And so it can slow down the progression. So it's not a cure, but it slows down how quickly the disorder can overtake them. All right, our next scenario is a 4-year-old boy presents to the clinic with a history of progressive difficulty keeping up with his peers when he plays in the park. He climbs stairs slowly and needs to hold on to the rail nowadays. On examination, his higher functions and cranial nerves are intact. His DTRs are 1 out of 4, and his gait is clumsy. He has no cerebellar signs. Which of the following is the best initial step in the workup of this child? A, MRI of the brain with contrast. B, MRI of the brain without contrast. C, muscle biopsy. D, serum CPK. Or E, genetic testing for Duchenne muscular dystrophy. All right, so the majority of people chose the right answer, which is serum CPK. So getting a serum CPK in patients who you suspect of having a muscular condition is a great place to start. Yes, it's true genetic testing for Duchenne's muscular dystrophy is very likely the route that's eventually going to come our way, but you need to start. It's asking you for the initial step of the workup of this kid. So we don't go directly to genetic testing. If you do that, the genetics department in your hospital is going to send them back to you and say, you didn't do anything and you sent them to us. So you need to start with blood tests for various muscle conditions. So you get a serum CPK first. Muscle biopsy is also something down the road that will need to get done, but not as an initial test. So that was good. All right, and so Duchenne's muscular dystrophy is X-linked. It can also be autosomal recessive, but is usually X-linked. And it's a deficiency of dystrophin. That's the component within the muscle that is deficient. It can be confirmed via genetic testing or through muscle biopsy. So for those of you who chose that in the previous question weren't wrong, but for the initial test, that's not where you go to first. There's a very high CPK level, so that's a great place to start your investigation. Usually presents between 2 and 6 years of age. They can have waddling of the gait. So remember we talked about people who have weakness in their muscles. They'll kind of work their whole body to get their legs off the ground. So that's a waddling gait. They can sometimes walk on their toes because it's just easy to kind of lock their toes in place and then remain on their toes. They can have calf hypertrophy. They can use that Gower sign, which I talked about, where they kind of walk up their body to stand up, and it's depicted in this picture here. So if they're sitting on the ground, they'll kind of first come to their hands and knees, and then they'll slowly kind of work their way up and then walk their hands up their body. They can eventually develop respiratory weakness and failure and have cardiomyopathy. So treatment is going to be supportive care. You can sometimes give steroids to help slow down progression. And there's a new medication which has been FDA approved called eteplirsen, which can sometimes help decrease how quickly the progression is for Duchenne's. And this picture is the calf pseudohypertrophy. And so the reason it's called pseudohypertrophy is because it's hypertrophied, but when you think of a hypertrophied muscle, you think of a strong muscle. So their muscles are actually very weak, but the calves are large. So it's a pseudohypertrophy. All right, and so we have myasthenia gravis, and so this is a disorder at the neuromuscular junction, which is over here in this picture. And so here we have the muscle. This is the nerve end plate. So we have a reduction in the postsynaptic receptors. So this is the synapse. This is presynaptic up here. This is postsynaptic. So these are the receptors. So there's a reduction in the receptors. So they can't, it doesn't receive those impulses that are coming down the nerve. And so there can be a few different types of it. There's congenital versus neonatal versus a juvenile form. So Congenital would be a patient who has the antibodies which are crossed through the placenta from mom who has myasthenia gravis, and that usually lasts for a couple of weeks, a couple of months, and then they grow out of it. Neonatal would be when they develop it because they've also inherited the tendency to have myasthenia. And then a juvenile form occurs in children. It just doesn't develop in the neonatal period. And so basically, they have anti-acetylcholine receptor antibodies. And what we do is, in order to diagnose it, is we basically want to fatigue the muscles, right? So we'll have them do repetitive muscle movements, or we can do repetitive stimulation on an EEG and see if the muscles become fatigued. They won't recover from fatigue as quickly as a normal muscle would. And we used to use the tensilon test once upon a time, but we've stopped using it because they can actually develop cardiac problems with that test, so we don't do that anymore. We do an EMG with repetitive stimulation. So they insert the EMG needle into the muscle, we give stimulation, and then we watch and see if those muscles become fatigued sooner than they should. They respond usually very well to pyridostigmine. Sometimes we need to do a thymectomy to remove the source of the abnormal antibodies. And plasmapheresis is also sometimes helpful to remove the antibodies that are already in the blood. IVIG can also be used. And a lot of times, by doing the antibody test, so there's acetylcholine antibodies that we can check for in the blood. If those are not abnormal, but we're still suspecting it, we can check for MuSK antibodies, which is a very specific type of antibodies which people with myasthenia can have. Guillain-Barré syndrome is a post-infectious demyelinating polyradiculopathy. And so what happens is usually after some kind of infection, either a respiratory or a GI infection, they can have an ascending paralysis, so they'll lose their deep tendon reflexes. They can have hypotonia of their muscles. They'll have weakness, and it can actually progress and ascend and go up and affect the respiratory muscles. So these patients need to be watched very closely. Usually, if not in the ICU, then you should have a very low threshold to send them to the ICU if they start to have respiratory involvement. There's usually not a specific sensory level because it usually starts at the feet and works its way up. So if you're constantly chasing a level, you won't find it because it's constantly moving. They can sometimes have optic disc edema, but it's not something that is going to make or break the diagnosis. Bladder function is usually preserved, but sometimes they need to have catheterization to help control the bladder function. And they very characteristically have something called cytoalbuminologic dissociation. So what that means is their albumin levels will be very high. So they'll have high protein in the CSF, but the cells will not match that. So their white cells will be normal, within a normal range, that is. And so that is usually very characteristic of Guillain-Barré syndrome, because usually if there's going to be high protein, there should be high cells also. So in this, there's just high protein. We treat this with IVIG, and we do not typically give steroids. It does not work. Botulism is also another condition which affects the neuromuscular junction, and it's very frequently seen after having unpasteurized honey. That's why we say don't give honey to kids less than a year of age. It can also be seen in people who live close to construction sites where there might be the Clostridial spores mixed into the soil, and if construction is being done, those spores can get aerosolized and ingested by people. So basically what will happen is the individual will have constipation, generalized weakness, they'll become areflexic and hypotonic and limp. They can have facial diplegia, so both sides of their face can be drooping and they can have weakness. They can have ptosis, absence of pupillary response to light. So what we'll do is we check the stool and look for those, the toxin, the Clostridial toxin, and then we treat it with an antitoxin. So the difference between myasthenia gravis and botulism, because they both work at the neuromuscular junction, is myasthenia gravis is at the postsynaptic junction and the botulism is at the presynaptic. They both can affect the pupils, except, I'm sorry, the pupils in myasthenia is normal. Pupils in botulism is very frequently, they won't have a normal response, they can have kind of a slowed response to light. So there, it won't be a fixed pupil, but it will be slowly responsive to light. Deep tendon reflexes in myasthenia gravis is typically normal, and in botulism will be decreased. In myasthenia gravis, you check for the acetylcholine receptor antibody, and in botulism, you check the stool for the toxin. All right, multiple sclerosis is a condition which can affect the central nervous system, so it affects the brain and the spinal cord. It can present with a whole constellation of symptoms. They can have weakness, they can have sensory symptoms, so they can have numbness or tingling in an extremity. They can have optic neuritis, so they can lose vision in one eye or both eyes. They can lose color saturation in one eye, so they might not see colors appropriately. They can have abnormal reflexes and ataxia. They can also have, and this is kind of an area which is getting more attention now, is that people with multiple sclerosis can have cognitive deficiencies. And they're starting to see that a lot of the people who have multiple sclerosis, they previously thought that it started in their 20s or their 30s, but they're now starting to see that they actually had a lot of their first time episodes in their teenage years. And it wasn't thought much of at the time by the teenager. They just thought, oh, my arm is limp today, or my arm is numb today. And, I probably slept on it wrong. But retrospectively, when we take that history, we sometimes see that that may have very well been their onset. And so they're starting to see that multiple sclerosis oftentimes is starting in the early teenage years or even sooner than that. So it is a disorder in pediatrics that we need to be aware of. So when working up multiple sclerosis, we will typically get a lumbar puncture, and we'll look for cells. We'll look for oligoclonal bands, the IgG index, and clinically we look for episodes which are dissociated in time and space. And so what that means is dissociation in time, meaning that they had an episode of whatever their symptoms were, either weakness or numbness, etc., and then they recovered and they get better because our body has a mechanism which we try to repair, injury repair, things that have gone wrong. So they'll get better, and then sometime later they'll have another episode. So that's called dissociation in time. And dissociation in space means that they have lesions, like in this image here, there's a lesion over here, and a lesion over here, and here, and here, and here. So these are in different territories in the brain. And we have maybe so these look like, these are bright lesions. So we would want to give contrast when we do an MRI to see if these are active lesions. So an active lesion will take up the contrast and it'll glow with contrast. So these, you would need to give contrast to see. And maybe there's a black spot here. So a black spot could indicate an old lesion that has now kind of repaired itself, but there's still a little bit of a scar there. So that would be the dissociation in space. You have lesions in different territories of the brain and lesions which look like they're of different ages. So the black spots are the older lesions. So for an acute exacerbation of multiple sclerosis, we treat it with steroids. We usually do 3 to 5 days of steroids, but usually IV, so high-dose steroids. In adults, we usually give a gram a day for 3 days. And we don't typically have to do a steroid taper if we just do up to 5 days of steroids. For long-term treatment, there's a few different lines of therapy that can be done. Interferon and glatiramer acetate are the first-line treatments, and there's a whole list of second-line treatments. The thing with pediatrics is that none of these are FDA approved, but we use them anyways because we know that they work, so we give them the same treatments that we give adults who have multiple sclerosis. All right, you ready for another scenario? We have a 12-year-old boy who presents with a history of ataxia for the past 2 years. According to his family, he has been deteriorating in terms of his motor skills and cognition. On exam, he has high arched feet and is wheelchair bound. Which of the following is the most likely associated comorbidity? A, renal failure, B, hepatic failure, C, cardiomyopathy, D, eczema, and E, retinitis pigmentosa. All right, majority of you chose the right answer, cardiomyopathy. That's great. Renal failure is something that can happen in a lot of myopathic conditions where there's disorders of the muscles. Cardiomyopathy is very suspicious for Friedreich's ataxia. So in Friedreich ataxia, you have high arched feet, stiff ankles, absent tendon reflexes, and very characteristically cardiomyopathy. So that cardiomyopathy makes it very suspicious for a Friedreich's ataxia. And we have acute cerebellar ataxia. So this usually occurs between 2 and 6 years of age. It is usually very sudden in onset. They'll have ataxia, hypotonia, so they'll have a low tone. They'll have a tremor. They can have horizontal nystagmus, dysarthria, irritability, nausea, and vomiting. And very frequently, they'll just present with having an inability to kind of stay still. They'll be wobbling all over the place. They'll have that ataxia. They'll have low tone, and they can't hold themselves up. They'll be vomiting and nauseous. Sensory and reflexes are usually normal. CT of the brain and MRI are also usually normal. An LP can be normal, but you can maybe see a little bit of leukocytosis, so the white cells might be a little bit on the higher side, but it's not diagnostic of it. It's in half of cases, it usually follows some kind of viral illness, either upper respiratory or a gastro illness. And most patients recover within 6 to 8 weeks without therapy. Sometimes you can give them some things to help their recovery along, speed it up a little bit, but usually it's, if you look up any literature for it, we don't treat it with anything and they usually recover on their own because it's a post-viral condition. Ataxia telangiectasia. So ataxia usually begins by 5 years of age. They'll have chorea, which is those sudden flailing movements. They can have myoclonus, which is those sudden like jerks of the muscles. So a chorea would be a more flailing movements of the limbs, whereas a myoclonus might just be a sudden twitch. They can have neuropathy, in which they might have decreased sensation in one modality or the other. They can have slurred speech. Oculomotor apraxia, so that if you want them to follow your finger across, they'll kind of have jerking movements of their eyes. It won't be smooth. They can also have immune system abnormalities, and they have a higher risk for leukemia because basically the ATM gene, it stands for ataxia telangiectasia mutation, it's affected, and so their ability to repair things that have gone wrong is not there. So leukemias are something that can occur more commonly in these kids as well as other abnormalities in their immune system. So this patient has a telangiectasia in the eye here. So this whole network of blood vessels is actually, it's not just a bloodshot eye, it's actually an abnormality in their blood vessels, it's telangiectasias. So you would differentiate that from a normal bloodshot eye because bloodshot eyes will go away. This is something that the patient has day in and day out. It doesn't go away. All right. Next scenario, we have an 18-month-old brought in by his grandmother who was babysitting him. She noticed a sudden onset in the child walking like a drunk, and his eyes are jumping back and forth. On exam, the child is alert, but there is vertical and horizontal nystagmus, as well as truncal and gait ataxia. His DTRs are normal. There is no focal weakness. Which of the following is the most likely diagnosis? A, drug ingestion, B, stroke, C, benign paroxysmal positional vertigo, D, subdural hematoma, or E, Guillain-Barré syndrome. All All right, so the majority of you chose drug ingestion, which is the right answer. Some of you chose C, which is benign paroxysmal positional vertigo. So, yes, when you have somebody with difficulty maintaining their balance and with eye movements, you would think of benign paroxysmal positional vertigo. But he had a sudden onset, and he's got the vertical and horizontal nystagmus, as well as the ataxia. So it's most likely, and not only that, but grandma was watching him, and so grandma might have some medications in her purse, so he most likely got into grandma's medication stash and took what she was taking, and I would guess that she has maybe some phosphenotoin or phenytoin in her purse, because that's very characteristic of a phenytoin ingestion when you have the nystagmus, ataxia, and difficulty with balance. So here's a mnemonic for differential diagnosis of loss of consciousness, AEIOU tips. So A is for alcohol and abuse, E, epilepsy, endocrine, electrolytes, encephalitis, encephalopathy. I is an insulin, so very high insulin or very low insulin. So hypoglycemia can cause alteration of consciousness, intussusception. Overdose or oxygen deficiency, so overdose of various medications can cause alteration of consciousness, uremia, trauma, tumor, infection, psychiatric, stroke, shock, and sepsis. A toddler with GERD and a recent history of otitis media is brought into the ED with a prolonged episode of neck extension and body stiffening. He is conscious and alert, but crying. Which of the following drugs is most likely to cause this reaction? A, cefazolin, B, ketorolac, C, metoclopramide, D, diphenhydramine, or E, ondansetron? All right, so the majority of people chose metoclopramide, which is the right answer, and D is diphenhydramine. So I know why some of you chose diphenhydramine. So metoclopramide is Reglan, right? We try not to use the trade names, but we're probably, at least I'm very used to calling it Reglan. And so with Reglan, or metoclopramide, we know that it can cause dystonic reactions, it can cause some movements, it can cause some inability to have smooth movements and some body stiffening. And so it's very kind of characteristic of metoclopramide use. And how do we treat it? We treat it with diphenhydramine. So we give the diphenhydramine to kind of counteract those the effects that the metoclopramide can use. So a lot of times in the ER, we can give these cocktails of medications for headaches or for other things. And part of them is sometimes giving Reglan to help control nausea and vomiting. And we'll oftentimes give the diphenhydramine in combination with it to help counteract the side effects. All right, so drugs that can cause ataxia and movement disorders. For ataxia, PHB is phenobarbital. Phenytoin is a very notorious one for causing ataxia. That's why I assumed that that grandmother had phenytoin in her purse, which the kid got into. Also alcohol. Thallium is not a medication that is typically used anymore. Carbamazepine can also cause ataxia. Tremor, anything that can stimulate the body, so stimulants, caffeine, theophylline, other stimulants that might be given for ADHD can cause tremors. Also, it can cause tics. Dystonia can be caused by phenytoin, so that patient in that scenario had like a dystonic reaction. Metoclopramide is also a medication which causes dystonia. Tics, so a lot of times we'll have patients who have ADHD and they'll be placed on some kind of stimulant medication and then they develop tics. So that's very commonly seen as a side effect to stimulants. All right, a 12-year-old male presents to the clinic with a history of recurrent eye movements, like his eyes are rolling up in his head, facial grimacing, and high-pitched squeaks at the end of each sentence. His father had similar spells as a child, but outgrew them in his early 20s. Which of the following constitutes a common comorbidity with this disease? A, depression, B, conduct disorder, C, obsessive compulsive disorder, D, cognitive impairment, or E, learning disabilities. All right, so the majority of people chose OCD. That's the right answer. Some people chose depression. So depression is something that can go hand in. So what does this patient have? Tics. So he has motor tics and he has vocal tics. And so there is a very clear correlation between tics and OCD. But anytime you have any kind of long-term condition, there can be depression associated with it. So yes, depression can be there, but it's not the common comorbidity associated with tics. So if you think of tics, I always ask, in my patients who have tics, I always ask them about OCD-like symptoms because there's a very clear correlation between the two. All right, so how do you know when to order the right test? So if there's an alteration of consciousness or a worst headache of my life, or an abnormal neuro exam, you should do imaging. So the easiest way to do imaging in an emergent situation is a CT of the head without contrast. CT will rule out a lot of acute things that we need to rule out. So blood, space-occupying lesions, tumors, et cetera, et cetera. It's not the best study, but it's the best in an acute situation. And when I say it's not the best, meaning it doesn't give us all the detail that we need, but it will help us with a lot of the things that we need to rule out. For muscle disorders, start with a CPK. That's a great place to start. For first-time seizures or febrile seizures, we don't need to do specific testing. We wait usually until the second seizure before we start considering doing EEGs or starting medications. For spinal cord injuries, we need to get an MRI to make sure that there's no compression or injury to the cord. A 16-year-old girl gets off a ride at an amusement park and is noted to have slurred speech and difficulty walking. On examination in the ED, she has difficulty with naming objects and comprehending instructions. Motor strength in the right upper extremity is 3 out of 5, and plantar is upgoing on the right. Which of the following is the most appropriate initial test to establish a diagnosis? A, CT of the head, B, angiogram, C, MRI of the brain, D, MRA of the brain and neck, and E, nerve conduction studies. All right, so a CT of the head. Most of you chose that, which is the right answer. That's good. And so what about D? A fair amount of you chose D also. D is a great idea also, but D cannot be done usually on an acute basis. So an MRA of the brain and neck, if you're in a larger institution, sometimes you can get those done immediately, but that's not always something that can be done immediately. We have to rule out a bleed within the brain first. Yes, you're correct that an MRA of the vessels is very important also, but getting a CT of the head it's a great test to be done emergently to rule out abnormalities. All right, so when taking the test, you want to always look for the safest option. Avoid doing LPs and other invasive procedures until other things are done. Avoid an LP until you've done imaging to make sure that there's nothing in the brain, which could be a space-occupying lesion, which would increase the pressure and cause the brain to herniate. Avoid unnecessary tests. They're usually not looking for you to order tests. They want you to counsel patients and educate them. Questions regarding the spine, always get an MRI. Questions regarding a raised intracranial pressure, do a CT scan first to rule out a tumor or a space-occupying lesion, and then you can go to doing an LP. If you have not heard of a test, it's probably not the right answer. So they're usually in board exams not trying to trick you. They just want to make sure that you understand the basics of things. All right, we have a couple more slides here. We're almost done. So we don't typically get an EEG for first-time seizures, or febrile seizures. For new headaches, we want to rule out things which could be causing an increase in the intracranial pressure, such as a tumor, any other kind of mass or pseudotumor cerebri. For seizures less than 2 years of age, you always want to make sure we don't have that Sandifer syndrome, which we talked about, which is the episodes that look like seizures, which are related to reflux. So it's good to get an EEG and try to capture an episode on EEG. And it's also good to take a very detailed history about the episodes, so make sure that they're not occurring in association with feeds. So right after a feed or within the first 30 to 40 minutes after a feed. First-time seizures usually don't need anti-epileptic medications. Most seizures within the first 48 hours of life are commonly due to HIE, hypoxic ischemic encephalopathy, and then they don't have seizures usually in the long run. They usually grow out of them in that neonatal period, most of the time. Folic acid, 0.4 milligrams for females, unless they've had a prior child with a neural tube defect, then you need 4 milligrams. And that is it. Thank you very much for your attention. If you have any questions, you can ask me afterwards or email me. I'll be happy to discuss things with you. Thank you.